ideal del médico. El ideal del médico que se forman en las diferentes universidades es aquel que al finalizar sus estudios ha adquirido todas las competencias que nos hemos propuesto en el perfil de egreso. Y estamos entonces hablando de competencias conceptuales,
acquire in the beginning of our education, the conceptual, procedural, and attitude competences. This is what we all strive for, and the more than 30 medicine programs in our country strive for. The question is, are we really achieving this? I have taken a syllabus or a summary of a syllabus of any, basically any medicine program in the country. You can observe that a syllabus includes learning results. And this is related to the competences. So the competences represent the bones of any graduate profile, which for all the medicine programs of our country are mostly the same. In the results of learning include communicational skills for students, which is incredibly important to establish the doctor-patient relationship. The syllabus speaks of necessary communicational skills to tackle issues with the patients, and it also mentions professionalism. So the syllabus includes professionalism as part of the learning results. Dr. Eduardo Facho published in 2009 a survey in which he questions what the attributes of professionalism are. Among the qualities listed are honesty, compromise, excellency, and our question today is how many of these qualities are actually in the graduate profiles of our medical graduates. Now I'm going to tackle the problems that we have today. In Chile, there are over 30 schools of medicine. In the USA, we have 44 for many more inhabitants. We have 33 for... so it's about one medical school for every 500,000 inhabitants. So we may have even an excess of medical schools. Last year, 200,000 students applied to medical professions, to health professions. And not only doctors, but also nurses and other professions. We can now see I now want to talk about a complete lack of standardization of the semiology subject in the schools. Our students are treated. Our students have these course in CESFAM, in public health institutions, because it is they are the ones that allow them to learn it. The preparation is also variable. There is no condensed standardization, and they are exposed to different numbers of patients. So it's all very variable. And another factor that plays an important role is the availability of resources. Some medical schools have high fidelity simulations and others have nothing. Some medical schools of our countries don't even have teachers, medical professionals to impart the subject of semiology. That's the reality of our country right now. What is the problem then? We want doctors of excellency. That's what we want as teachers. That's what our health ministry wants. That's what our community wants. What do the clinical field say? We have few students in our hospitals. Hospitals decide whether they will accept students or not. So we place our students in one medical service and they can't move from there. Gone are the times where the students join the doctors in doing examinations and scans and all of the diagnosis process. That is the current situation of the availability of teachers and resources that we have today in our field. And therefore, the student and patient contact is getting diminished more and more.
After 1 year of teaching semiology, seeing the ill, examining them, that is what we are not doing today, and we need a solution for that.
Y para terminar esta parte tan incómoda, tenemos la ley de derechos y deberes de los pacientes. Los pacientes hoy no se puede filmar, tienen su privacidad y los derechos.
They have their privacy and their own rights,
está todo el tema de la infección intrahospitalaria, también es correcto y se entiende. No puede en una sala haber 10 TENS, 8 enfermeras, 5 becados, 2 médicos, malos enfermos, imposible. Aquí, el doctor Mella generaría un conflicto al respecto. Hay falta de estandarización de la enseñanza en la semiología. Nosotros no tenemos semiólogos. Todos los que hemos enseñado semiología, me refiero a que no estamos profesionalizados en la semiología. Todo lo que hemos enseñado semiología por años, nadie nos dijo cómo enseñar semiología. Empezamos a enseñar semiología de forma espontánea, por naturaleza. Y algunos lo hacen bien, otros no lo hacemos tan bien. No hay profesionalización del tema. Y finalmente, en este punto, hay un punto que es importante, que es el uso excesivo de la tecnología. Hoy todo es escáner, todo es resonancia, el método clínico no existe. Hoy se examina muy poco a los enfermos y eso, estudiantes, debe eliminarse. Los enfermos deben ser examinados, deben ser olidos, tocados, palpados, escuchados. Esa es la pregunta que dejo presente entonces. En este mundo tecnológico tan fuerte, tan arrollador, ¿existe algún lugar aún para la semiología médica? La semiología médica es una asignatura de alta relevancia porque tiene un componente que es multidisciplinario. Es una asignatura que nos obliga a desarrollar habilidades de comunicación. Tenemos que examinar a los enfermos. Tenemos que interpretar lo que estamos viendo y eventualmente plantear diagnóstico. Tiene un rol integrador. La semiología es la base para incorporar otros saberes. Es el cimiento de otras clínicas, es el cimiento para la obstetricia, para la pediatría, para la psiquiatría. Finalmente nos permite adquirir una comunicación efectiva tan importante en la relación médico-paciente. Por tanto, no es menor, es su asignatura vertebral en la formación de ustedes como médicos. Dentro de la semiología,
within
y simulando
semiology
lo que es el método
and
científico,
thinking about the scientific
tenemos que desarrollar lo que
methodology,
es el método
we
clínico,
have to develop what it is
que es lo que nos va a guiar a un
clinical
diagnóstico
method,
y
which
eventualmente a
will
un
guide us
tratamiento.
to a diagnosis
Si no
and
trabajamos el
treatment.
método clínico,
If we do
mal
not
podremos
work
llegar
on
a un
this,
diagnóstico
we
definitivo.
won't be able to have a definite
Siga la flecha.
diagnosis.
Si no hacemos
Follow
eso,
this line.
tener una estandarización
If we
en el
don't
análisis de la
have
anamnesis, signos,
standardization
síntomas, integración,
between
interpretación,
signs,
vamos a perder.
symptoms, integration, we will be lost.
Se dice que el médico
They say that
debe ser un hermeneuta,
physicians has to
es
be,
decir, debe tener la capacidad de efectuar todo este tipo
mean,
de cosas que
they
están
have
en la
to have their
diapositiva frente a sus
availability
enfermos. O sea,
to-
tenemos que observar a los enfermos,
to do all
tocarlos,
of this,
mirarlos, oler,
look at the
palpar,
ill,
oír,
touch them,
escribir, volver a
smell
mirar,
them,
concluir y si es necesario
look
volver a
again,
examinar.
make a conclusion, and
Tal
if
vez
not
lo que está
possible, then
planteado
examine
se
again.
presenta en forma un poco excesiva,
So maybe
pero lo que hay que tomar es el
what
mensaje
I'm
de lo que
saying
hay.
is too much, but we need to get to the core of this.
¿Cuáles son las habilidades que se requieren
Which are
en la
the
correcta
abilities
aplicación
that we
del método
require in
científico
the
y
right
que deben enseñarse en la
application of
semiología?
clinical method,
Primero
and that
tenemos
have
que
to be
enseñar a
taught
nuestros
in
estudiantes a
semiology?
comunicar.
We have to teach our
Segundo,
students to
identificar la
communicate.
búsqueda de los signos
Then to
clínicos.
identify the search of
Tercero,
clinical
interpretar.
signs. Then
No
to
basta con
interpret.
escuchar los
We do
síntomas y
not
los
only
signos,
need
sino que
to
también tenemos que
hear
aprender a
these
interpretar,
signs and symptoms, but we have to
diagnosticar
interpret
y
them.
finalmente
To
intervenir
diagnose and then
con
finally
prevención,
to
por ejemplo,
intervene
con rehabilitación u otro.
with prevention, rehabilitation,
Y
and
esto
some
del
others.
método clínico al cual hago referencia
And
como
what I mean
la
with the
herramienta por la
clinical
cual se
method,
tiene que
which is the
trabajar la
tool
semiología,
by which we
creo que
work
hoy día existe
semiology,
una crisis.
there is a crisis.
Existe una
within
crisis
this.
porque hay un deterioro de de la
Because
relación médico-paciente. De
The
lo contrario,
relationship
usted me
between
podrían
physicians
decir
and
lo
patients is not good.
diferente a lo que está puesto ahí.
Would you
El
say
médico, el paciente,
something
su relación
different of
mutua
what
se hallan
I'm
en mejor
showing you
situación
here?
ahora que hace 50 años. La verdad es que no.
Do
Hoy día
doctors
lo que ha
and
ocurrido,
patients have a better
se ha generado
relationship
un
than
estallido
what they
tecnológico
did in
impresionante.
50 years ago?
Pero
The
paradojalmente,
truth is,
junto con
it is
ello,
not like that.
la frustración y la
There
insatisfacción
is
de
a
los
lot of
pacientes
frustration
en relación al
and
cuerpo médico ha aumentado.
insatisfaction from patients.
Entonces no hemos
regarding
sabido
the
probablemente
work of
llevar las dos
physician.
cosas en paralelo.
This is maybe because we have not know how to deal with technology.
La relación
and the
médico-paciente
relationship
también
with the
cambió.
patients.
Hoy se habla del concepto del
There is a
i-médico y
change
el
between
i-paciente.
this relationship.
El i-médico que está con su
Today we talk
computador, ¿no
about
es cierto? Pide la resonancia de última
physician and
generación.
e-patient.
Y el i-paciente ya
Ya
no es el paciente de antes.
25
25 siglos atrás teníamos una relación, tenían una relación casi paternalista con los enfermos. El médico era como el papá del enfermo, lo cuidaba, lo consolaba, lo escuchaba. Bueno, hace 50 años que eso se viene perdiendo muy rápidamente. Y hoy día no existe, porque el paciente también cambió. Hoy tenemos el paciente con el reloj digital que le da el pulso, el electro, la saturación, la frecuencia cardíaca, le dice el tubo arritmia, no tubo arritmia, anda con el smartphone, se comunica, va y viene, vuela, viaja, se globaliza, exige sus derechos, conoce bien su actitud, sus problemas previsionales, quiere diagnóstico rápido, y si el médico no le pide examen, él le dice al médico, yo quiero que usted me haga examen, a eso vengo. Entonces, todo ha cambiado. La relación médico-paciente absolutamente diferente a lo que existía antes. Hay un menosprecio de la clínica. Existen muchos médicos que no examinan a sus enfermos.
There are a
Ni
lot
siquiera
of
toman la
doctors who do not
Eso no está bien.
examine their patients.
No debemos saltar
They
los
won't
pasos
even
en el
take
método
their
clínico.
blood pressure,
¿Y
and
por
that
qué
is not possible.
es importante que examinemos
Why
a los
is it
enfermos?
important that we examine our
Porque
patients?
existen muchas enfermedades que
Because
requieren
there are a lot
solo
of diseases
el examen físico
that
para hacer el diagnóstico,
require only a physical
porque
exam
permite reducir
in order
costos
to get a
innecesarios,
diagnosis. It
permite hacer
allows to
diagnósticos
reduce
precoces
unneeded
y porque refuerza la relación
costs,
médico-paciente.
and
De
it
hecho, hay una serie de
reinforces the
instituciones que
relationship
hoy
between doctor and
sugieren
patient.
no
There are
pida tanto
studies
examen como lo que ustedes
that
ven ahí.
today suggest
Si
that we
ustedes
do
tienen
not
un
need
paciente
that
que tiene
amount
una
of
insuficiencia
exams
de la válvula mitral
that we are
leve,
doing.
¿tiene algún sentido pedirle todos los años un ecocardiograma?
If you have a
En absoluto.
patient
El paciente
with
lo pueden
a
auscultar, lo
diagnosed
pueden interrogar, lo pueden
heart
examinar.
disease,
No
do
es
you need
necesario.
every year
Estoy dando solo un ejemplo.
EKG, this is just an example.
Sabemos que solo con la anamnesis
We
podemos
know
alcanzar el
that only with
65% de
anamnesis
aproximación en
we
un
can
diagnóstico.
reach
Le agregamos un 15% con el examen físico y un
65%
20%
of
con
a
los exámenes.
diagnosis, then 50% with
El tercer elemento por el cual hay una crisis del método clínico y por tanto de la
physical
enseñanza de la
examination.
semiología es la sobrevaloración de la
There is
tecnología a la cual ya
also
hice referencia. La pregunta es, si el método clínico no sitúa al médico en el camino del
we
diagnóstico,
overvalue
método
technology.
clínico, es difícil
Now,
entonces que lo
If
oriente
we
el
do
uso de
not value
tecnologías.
clinical method,
O sea, si
it is
partimos solicitando
hard
primero exámenes
to
y
be
no,
guided by
no
the use of
interrogamos y examinamos a los
technologies.
enfermos,
if we do
es
not
difícil que aunque recibamos exámenes,
patients,
hagamos
it is
una
hard for
correcta
us
interpretación.
that we are able to interpret the exams.
Y finalmente hay un desinterés por la atención primaria.
And
El
then
médico en atención
we lack
primaria hoy día es
interest
como
of medicine
patio
in
trasero,
primary attention.
lo que es un
That is like
tremendo
the
error,
backyard
porque es el médico de
some
atención primaria
physicians.
el que utiliza
And
sus
that is a
5
mistake
sentidos.
because it is this
para hacer
doctor,
diagnóstico.
the one who uses their
El
5
especialista
senses
está
to
habitualmente
make
sumido
a
en un ambiente de
diagnosis.
mucha tecnología, rodeado de muchos colegas, no tiene problema.
Physicians
El
are
médico de atención
now surrounded
primaria
by a lot
aquí
of
es el que está a la
technology,
vanguardia de la
and
medicina. Y por lo
this
demás,
doctor does not have
la
that
atención
problem.
primaria es el esqueleto vertebral de cualquier
Moreover,
servicio sanitario de cualquier país.
These are the essence of the healthcare system in a country.
Vamos a la última parte de la presentación.
To the last
¿Qué
part
podemos
of our
hacer o qué
presentation,
alternativas tenemos para la
what are we
enseñanza
able
correcta de la semiología?
to
Y aquí
a
tenemos un
proper
montón de alternativas. Primero,
instruction of
clase
semiology.
electiva
There
de
are a
semiología.
lot of
Todos hacemos
options.
clases de semiología
One
en
of them
diferentes
is
especialidades y eso
to
sin duda que se puede mantener.
give
La enseñanza tutorizada con pacientes
Semiology
y por áreas
instruction.
en un hospital
the other
es
one
algo impracticable.
is
Es
to
decir, si me llega
teach
un estudiante o 5
by the
estudiantes y
different
tengo que enseñar
areas.
solo
If
semiología
I
cardíaca,
have
es
5 students
prácticamente imposible de
and
hacer
only have to teach
con el
them
número de estudiantes que tenemos.
hard semiology,
Pero sí
it
se
is
pueden
hard
hacer
to
talleres
do
de examen
with the
físico,
amount
por
of
ejemplo, con
students that we
fantomas.
have,
Y algunas
but we can
universidades de este
we
país lo
can
hacen.
teach them
La simulación
with
clínica con
simulation.
actores y con
Clinical
actrices
simulation
también se
with
puede hacer. Y
actors
eso
and actresses.
permite esencialmente
This
desarrollar
allows
mucho
to develop
el resultado de aprendizaje de la comunicación.
the result of
Generar una
communication.
plataforma virtual de semiología.
To produce
Yo creo que
a
esto sí
virtual
lo podemos hacer
platform of
nosotros como
semiology.
facultad.
I do think that we
Una
are able to do this as a
plataforma
faculty,
virtual
a virtual
que esté
platform
enriquecida con imágenes, con
that
casos
is
clínicos,
enriched
con
with
videos,
images,
con
clinical
audios,
cases, videos,
con
audios.
talleres, se puede enriquecer muchísimo
workshops.
una plataforma que
We
sea de
can do
uso de los
this
estudiantes, en que
for
incluso
the
podría
use
tener
of our
incorporado
students, and we can
algún
even add
método de evaluación.
some evaluation method.
Podemos hacer talleres de semiología con
We
simulación
can
y
have
finalmente
workshops of
hacer una
semiology
enseñanza
simulation,
tutorizada en
and
hospital
also
con pacientes reales,
tutorized
que es la forma
teaching in the
tradicional
hospital,
con la cual
which is
muchos
the
nos hemos
traditional
formado.
method.
En el fondo, mi mensaje es
The many of us
debiésemos
have had.
retornar
Then my
al
message
hospital
it is to
en
go
los
back to the
tiempos más
hospitals
adecuados y
in
con
the
más flexibilidad para utilizar
proper
eso como
times
campo
and more
clínico.
flexible times to get this.
En el mundo están saliendo permanentemente
In
diferentes
the world,
artículos sobre cómo
we
enseñar
have
semiología.
a lot
Y
of
aquí puse un ejemplo.
papers about
Ustedes
how
saben
to
que
teach
existe la
semiology.
neurofobia, es decir,
You know that
esto
we
de
have
examinar a
neurophobia,
los enfermos con algún daño
which
neurológico, existe
is
como cierto rechazo a eso,
like
¿ya? Es
this
como que cuesta mucho. Bueno, aquí hay un ejemplo, este es un
rejection
trabajo que se
to-
hizo, me parece que fue en París,
to assess
Y
patients with
a través de
neurological
mimos
problems.
simulan, por ejemplo,
And-
un daño piramidal o un daño cerebeloso,
and
lo teatralizan y con eso los
some
estudiantes
actors
aprenden
can
fácilmente, de
perform
forma casi
these
entretenida, lo que son los grandes
type of
síndromes
problem
neurológicos.
of
Algo que se
neurological
podría
problems,
hacer
which is
y
something
practicarlo.
that we can do and we can practice.
Y finalmente quisiera señalar que el futuro de la
And
semiología
I
en
will
realidad
also
es
like
un
to add
poco
that the future of
cierto,
semiology
con
is
tanto
uncertain
que se habla hoy sobre la inteligencia
with
artificial.
what we talk
Es
about.
probable que en 10 años o tal vez antes estemos hablando de otra cosa y la inteligencia artificial lo haya resuelto todo. De hecho, esta es una revisión de los últimos años en que hay más de 4.000 publicaciones y demás, sobre el uso de la
than
inteligencia
4,000
artificial en
publications
la
about
educación
the
médica.
use of
Y esto
AI
probablemente se
in
va a
medicine,
triplicar en el transcurso del
which
tiempo.
might
Por tanto, es difícil dar
triplify
una
over the
respuesta
time. So it is
de cuál
hard
es
to
el
find
futuro
an
real de la
answer
semiología.
of what is the real
Eh,
future of semiology.
Sin embargo, quería terminar con esta
However,
diapositiva
I
que, a
want to
pesar de lo
finish
que
with
acabo de
this
decir,
slide.
creo que debemos
summarizes what I just
recuperar
said.
en la
I
formación
think we
médica la
have
enseñanza
to
de una medicina
Take
más
again
humana.
the teaching
Y ahí
of
puse
more
entonces una diapositiva de hace varios
humane
siglos atrás
medicine.
y una diapositiva
I
de la medicina que tenemos
put
hoy.
a slide of an image
Muchas
of
gracias.
medicine of thousands of years ago and what we are doing today. Thank you very much.
Agradecemos al doctor
We
Gajardo por su
thank Dr.
excelente
Gajardo for his excellent presentation.
A continuación, es un honor presentar al
Now,
doctor Sergio
it
Mella
is an honor
Montesinos, profesor
to
titular de la Facultad de
present
Medicina
Dr.
de la Universidad de
Sergio Mella
Concepción
Montesinos,
y
head
residente
teacher of
incorporado en
our
miembro correspondiente
Faculty
a la
of
Academia
Medicine.
Clínica de Medicina. El doctor Mella
Dr.
tiene una
Mella
vasta experiencia
has
en el
vast
campo de las
experience
enfermedades
in the
infecciosas
field
y ha formado a
of
decenas de
infectious
generaciones
diseases
en la
and
práctica de la
has
medicina
shaped
pulsada.
generations in the
Actualmente,
medical
se
practice
desempeña
with
como
patients.
encargado de la asignatura de
Currently,
semiología de nuestra
he
facultad.
is
Hoy
in
nos
charge of the
compartirá su presentación
semiology
titulada
subject in
Historia
our
nacional
university.
y local de
Today,
la docencia semiológica.
he will
Lo recibimos
present
con un fuerte aplauso.
his presentation about local history of semiology.
Muy buenos días.
Good morning, everyone.
Muchas gracias por la invitación.
Thank you very much for
Queridos
the
organizadores,
invite
agradecemos la
to this
presencia tan
seminar.
destacado visitante extranjero.
And
Y yo
I
siempre
would like to
digo que la
acknowledge the
tecnología
presence
por sí
of our distinguished international guests.
estas luces, pero me dijeron que el doctor le estaba golpeando no sé qué cosa y yo le saqué esto y no se vio nada, pero bueno, es algo muy propio mío. En serio,
He
efectivamente.
describes an
Y bueno, y
anecdote
hablando de
that
eso, por
happened to
tanto, yo
him.
obviamente voy a estar muy de acuerdo con lo que planteó el doctor Gajardo.
I
Es un
want
hombre
to agree
poco
wholeheartedly
tecnológico,
with what
ni que
Dr.
con
Gajardo said.
los niños. Voy pasando yo las diapos. ¿Pueden bajar eso un poquito? No, un micrófono más cerca. No, pero se escucha, ¿no?
Can you all listen to me?
Incluso si algo de acá se escucha. Ah, perdón.
Some technical mishaps.
No, me quedo acá. No hay problema, sí, pero la luz un poco, ¿no? Pues, bien, brevemente algunos conceptos que fueron
Okay, I want to briefly present
ya
some
señalados
concepts
por
which were pointed out by
Doctor.
Dr. Gajardo.
por el doctor. La flechita. No, si la flechita quiere. ¿Cuál es la punta ahora? Ya. Bueno, la semiología y la
So,
semiótica. se
semiology
refieren al
and
estudio de los
semiotics
síntomas,
refer
los
to
síntomas.
the study of symptoms.
Y hay varias teorías
And
¿no
there
es
are
cierto?
various
generales de
theories and
esto, de manera
general
que la
concepts
semiótica y la semiología
that
están
are
presentes en
encompassed
varios campos. Ya
within
nombró
semiology
el
and
doctor
semiotics.
algunos de los creadores,
These are
¿no es cierto?
present in various
Fundamentalmente
fields.
Saussure, un filósofo suizo, después un
The originator
gran
of the term
investigador
semiology
norteamericano, ¿no es cierto?
was
Y,
Ferdinand de Saussure,
estos contenidos de la
a Swedish
semiología
philosopher,
están arraigados en
and these
múltiples áreas
concepts
del conocimiento
are
humano.
encompassed in
Em,
several areas of human knowledge.
En un esfuerzo, no sé acaso
In
fue
an
estéril o no,
effort,
porque yo creo que aquí hay
that
es un tema
I
súper
don't know if
complejo el que
it
estamos
was
analizando sobre, ¿no es cierto?
an aesthetic effort or not, because this is
la
a complex
enseñanza de la
issue that
semiología, ¿no
we're
es cierto? De la- y de
discussing.
lo-
Semiology and
clínica,
its
¿no?
importance
Hay
in the
varios
clinical field.
elementos, probablemente la mayor parte dice en relación con nuestra
Um,
capacidad de
The most
encantar a los
part of
alumnos.
it
Pero también
is related to
em,
our
creo
ability
que
to
de
charm
alguna
the
forma
students.
hay una falta de interés de un
And
grupo
but we
probablemente
also
menor de nuestros
believe that there is
estudiantes,
a lack
que
of
probablemente esté
interest
relacionado con nuestra,
that
nuestra poca capacidad
might be
de
related
poderlos
to
incentivar.
our little
Porque de hecho,
ability
en
to
el curso
encourage
de
you and
este año y el año
stimulate
pasado,
you.
yo les entregué, ¿no es cierto? De Loren Binet,
This time last
en
year,
su,
I
excelente novela La séptima función del lenguaje, le hice imprimir
I
una explicación para
handed
que el chiquillo entendiera lo que era la semiología. Entonces, aquí está
a copy of the excellent novel, The
investigador francés,
Seventh
un
Function
policía
of
para allá.
Language, so
Había
that
habido
you
un
could have
asesinato de un gran
a grasp of
filósofo
what semiology
en
is.
Francia y va a ubicar a un gran profesor judío francés, ¿no es cierto?, a la universidad, y este profesor judío a los franceses, en el relato le dice, este es un hecho de un curso especializado en la semiología. Bayard era un policía, era un hombre bastante más rudo, un hombre de acción.
Policeman.
Le pregunta concretamente, ¿para qué sirve esa ciencia?
He is asked what semiology is for, what that science
está
is for.
impaciente, ¿qué es esto de la semiología?
And he's impatient, he doesn't understand
dice, por
what
ejemplo,
semiology is about.
esa silla en la
And
que usted está sentado,
the
con su
professor
grado
tells
cero de
him,
diseño, su
this
mala
chair with
madera
your
barnizada y su
sitting
armazón
on,
oxidado,
it's rusty
nos dice que
frame,
estamos en un colectivo
and
que carece de
its
interés por
dirty
el
looks
confort y por la estética,
gives away
y
that
que
we are
además no
in a
tiene
collective
dinero.
that lacks
Sí.
interest in aesthetics and comfort.
Añadido a esto, le explica a este profesor
In addition to
francés
this,
brillante, la mezcla de olores
the professor
en el comedor, a comedor
claims
barato
that the
y cannabis nos confirma que
mixture
estamos
of
en un lugar
smells
universitario.
to a cheap dining room and cannabis can confirm that we are
Brillante.
indeed in a university campus.
No, yo la digo brillante. Usted lleva,
I think
¿sabes qué le
it's
dice
a bright
este
observation,
profesor
a brilliant
a
observation.
Bayard, que es el investigador, el hombre mudo, ¿no es
Bayard,
cierto? El
which is
hombre
this
que de hecho había estado
detective
en el ejército,
in the
podemos
novel,
haber conversado de esta novela. Pero bueno, lo que delata un empleo
is
de
wearing,
ejecutivo,
tells him
barato,
that he's wearing
lo
a
que
suit,
implica un salario
which gives
modesto
away
y
an
una
executive
falta de
job.
interés por su
However, it is
apariencia.
cheap and it
Por
gives
tanto, se
away
dedica a
a
un
modest
oficio
salary and
en el
a
que la
lack of
presencia
interest in
formal no
appearances.
cuenta o cuenta poco.
Therefore,
Sí.
you are
Sus
dedicated
zapatos están
to a
gastados,
work in
pero
which
como ha
formal
venido en coche,
presence
significa que
doesn't
no se
account
queda
for
mucho
much.
tiempo sentado en su
Their
despacho,
shoes are worn,
sino que en terreno.
but since he came in a
Un
car,
ejecutivo
it
que
means
está
he doesn't
poco en
sit
su
in
oficina, tiene
his
todas
office
las
for long,
papeletas de estar destinado
but he's
a un trabajo de inspección.
he goes out
Hay un
in the
empleo
field.
entonces en forma
An executive
brillante,
that isn't in
lo que
his
es la
office a lot
semiología en general,
has
y eso hay que
all
aplicarlo en la
the
clínica. Lamentablemente tengo que
probabilities to
decir,
be
lamento
destined
que más de algunos se van a molestar
to an
conmigo,
inspection job, and
muchos de mis alumnos
therefore
no se
he
leían esto, a
infers
pesar que se los
what
pedí 3 veces que lo
he does for a
conversaran.
living.
¿Ya? Entonces es una realidad que hay que decir.
This is an extract of the
Ahora,
novel The
Esto
Seventh
pasa en todas
Function
partes,
of Language by
un
Binet.
internal medicine, ¿no es cierto? En un estudio donde estudiaban
So,
eventos adversos y la etiología, se realizaron más de 30.000
Study
fichas, en un grupo muy especializado que incluía a 2
which
médicos, pero en
was
fondo
done by a
mostraban una
highly
viñeta de un
specialized
caso
group.
que era categórico, ¿no es cierto? Durante
I
una
want to highlight a
aborto
categorical
una paciente tenía
case.
13 semanas de embarazo, ¿no es cierto? Los médicos
During a
de forma
therapeutic
inesperada,
abortion after 13 weeks of
perforaron la
pregnancy,
pared uterina, ¿no es cierto? Con un
the
aparato de
physicians
succión y la cerraron el colon. La
unknowingly
paciente
perforated the
reportó
patient's
un dolor
uterine wall with a
intenso,
suction device
intenso,
and lacerated the
pero
colon.
fue descargada,
The patient
¿ya?
reported
Sin
severe
evaluación.
pain but was
Y
discharged
ella
without
retornó una hora más
evaluation.
tarde al hospital,
She later
a la
returned
emergencia, ¿cierto? Con un
to
dolor que
the
era aún
hospital
peor.
emergency room with
y,
even greater
sospecha de
pain
sangrado.
and evidence of internal bleeding.
Y ella requirió, ¿no es
She
cierto?,
required
cirugía
to stage
compleja,
surgical repair
en 2 tiempos,
over
¿no es
the
cierto? Tuvo que
ensuing
haber
4
habido,
months.
obviamente, alguna ostomía y después una reconstitución de tránsito,
There
etcétera.
was
Y obviamente en este artículo el evento fue considerado adverso
obviously,
debido a negligencia.
the event was considered
Y
adverse
eso
due
nos
to
habla, ¿no es cierto?,
negligence
que
in
también
this
la
article.
semiología sigue siendo
So this tells
útil,
us
no
that
solamente en la literatura, sino en el mundo real,
psychology
y no
is
solamente en
still
países
being
subdesarrollados del tercer
applied
mundo como el
not
nuestro, sino que
only
también en el
in
primer mundo.
literature
Y
but
ahí viene, ¿no es cierto?, lo que estaba
the real world
conversando
and not
el
only in third
doctor,
world countries
de
but
que
also
algunos
first world
ejemplos,
countries.
y lo más probable que esta enferma, ¿no es cierto?, tenía gran dolor y haya tenido
It is
sin duda una
likely
perforación de una víscera hueca
that
y haya tenido
this
¿qué
patient
clínicos mínimos había
underwent
tenido?
severe pain.
El más clásico, Bloomberg, exactamente, Bloomberg, y probablemente ese abdomen haya
And-
estado estable, y así podríamos haber seguido, ¿ya? La semiología, que tiene otro nombre, ¿no es cierto?, en la literatura anglosajona, pero estamos
Semiology
hablando
has
lo
a
mismo,
different name in
de
Anglo-Saxon
examen
literature,
físico,
but
physical
we're
examination,
talking
entre otros,
about
en la
a
literatura
physical
anglosajona,
exam,
pero sigue siendo algo
examination.
extremadamente útil. Y ahí
And
tiene un ejemplo
It's
como
still
en un
something
país del primer
extremely
mundo,
useful.
la
I
falta, ¿no es cierto?, de
already
atención a un
told you
síntoma
an example
cardinal de la medicina,
in
que
which
era
a
el
lack
dolor
of
intenso,
attention
después de un
in a
procedimiento
medical center
quirúrgico, un procedimiento
after
invasor,
a
no fue pesquisado
surgery
y no se examinó al enfermo.
was ignored
Tal
and
como señaló el
the
doctor, y
patient
esto va a ser
wasn't
redundante,
examined.
creo, los circuitos redundantes, hay que
Maybe
acordarse que los circuitos redundantes
this is
en
redundant,
el mundo están
but,
fundamentalmente, fueron
uh,
muy valorados
the-
en la industria aeronáutica, ¿no es cierto? El doble chequeo.
we can
Y eso también pasa en múltiples áreas,
see
incluso
how
en medicina,
the
y particularmente cuando
semiological
menos desarrollado sea el
knowledge
país.
is
Ahora,
undervalued
en este
in
marco,
today's world.
vamos a volver a insistir en eso, entonces, que hay una subvaloración del saber semiológico clásico, por, ¿no es cierto?,
the
esta
classical
obsesión con el
semiological
desarrollo tecnológico, obviamente,
knowledge,
incrementa el
because we have
conocimiento, la
this
posibilidad de
kind of
diagnóstica, la
obsession
confirmación, etcétera,
over
pero como todo en la vida, y lo más difícil,
indiscriminate use
obviamente,
of modern
¿dónde está ese
technology.
equilibrio?
So where can we find this balance
Y aquí, por ejemplo, hay
between
otra,
these two very important parts of
editorial, perdón, un artículo opinado en
medicine?
New Internal Medicine, ¿no es cierto?, sobre el uso del
We
estetoscopio.
have an
Y
extract
que, este
of
autor señala que esta es una herramienta que
the
tiene un
use
gran valor
of
clínico si uno lo sabe usar.
stethoscope,
Pero, ¿no es cierto?, él señala que estamos
where
acercándonos
the
a otro
author
fin,
points out
¿ya?
that
Todavía
it's
no
close
parece ser un
to
objeto de museo como
being
cuando los
obsolete.
médicos medievales
It
miraban
is
los
still
frascos
not
de orina,
considered a
pero
museum
para
item,
destacado investigador,
like
¿no es cierto?, lo más
medieval
probable que en un
physician's
tiempo
urine flask,
no muy largo esto
but
vaya a
it
ser
is
más bien
likely that this will become a
especie
reality
de
in
artefacto
a
anecdotal.
shorter time than
Como invitado a
we
hablar
can
a mí, yo voy a dar
imagine.
mi opinión personal. Yo creo que nosotros
I want
estamos
to give
lejos
my
de eso. Somos un país
personal
subdesarrollado
opinion.
y por
I think
tanto,
we are
es
still
cuestión de
far
que
from that
nos
as
ubiquemos
a
donde
country,
estamos, qué creaciones científicas
as an
realizamos
underdeveloped
nosotros,
country.
qué grandes contribuciones a la ciencia, qué contribuciones tecnológicas desarrollamos. Muy pocas.
And
¿Cierto? Aquí tenemos un profesor
we
norteamericano,
have
compárense.
no great
Casi todo lo que
contributions
estamos
to
usando
medical
acá viene del país
technology.
del norte en tecnología.
Almost
nosotros
all
tenemos
of the
que
tools
saber
that we
usar
use come from the
lo
north
que
part
podemos
of the
usar
world.
en forma mucho más provechosa. Y una de ellas son las herramientas clínicas.
But
La
we,
anamnesis, el examen físico.
there are
Ahí
tools
está
that
nuestra
we can use in a much
Nosotros
more
no vamos a
advancedful
inventar una
way,
nueva máquina que va a secuenciar más rápido el
which
genoma
are
humano.
the classical tools.
Nosotros no
We're
vamos
not
a
going to
inventar un
invent a
dispositivo
new
que nos
machine
permita
that
ver la función de las
allow
proteínas,
us
acaso están activas o no están activas,
to
etcétera.
see
Entonces eso tenemos que tenerlo
what
súper
functions
claro.
are
Por
active
tanto, tenemos
or
que
aren't. So
enfatizar
we
aquellas
have to
áreas que
be
sí podemos
clear
desarrollar. Y una
about
de ellas
this,
es
and
esta medicina
we have
tradicional,
to
basada en los
be
elementos
clear about
clínicos.
which areas we can
¿De
further
qué quiero hacer
develop.
realza esto?
And
Porque
some of
Chile
these,
desarrolló muy bien
and
esa
one of
área
these is the use
y
of
tiene una
medical tools.
historia al respecto. Y los logros de la medicina chilena se fundamentaron en
The
muchos de
achievements
nuestros
of
profesores y
Chilean
también profesores
medicines,
que formaron a nuestros profesores.
of Chilean
Y ahí tienen
medicine,
un rol destacado la Universidad de Chile.
were
Y este prohombre de la medicina chilena,
come
Hernán
mainly
Alessandro
from
Rodríguez,
the
se
University
incorporó
of
al Hospital
Chile.
del Salvador en Santiago en el año 1931. Este señor
Dr.
era hermano del
Hernán
presidente de la
Alessandri
República.
Rodríguez was
Y
an
también
important
nos habla de
exponent of
nuestra
this.
historia, de lo que somos.
Uh,
¿Ya? En la literatura anglosajona
the-
no existe la palabra golpe de Estado.
In the
Tuvieron que
Anglo-Saxon
tomar las palabras
literature,
del francés.
there
Por su
isn't
estabilidad
a word for
democrática.
coup d'état.
Este
It
señor
is
se
a
fue de Chile y
borrowed
su
word
familia
from French.
por un golpe de Estado. Pero como era un hombre
However,
muy capaz, aprendió
this
medicina en
man,
distintas partes del
Hernán
mundo y
Alessandri
trajo hacia
Rodríguez, had
adelante
to
a Chile.
leave
Y vean lo que significó.
Chile because of the coup d'état
Fíjense,
that happened
profesor de
here,
la cátedra
and
extraordinaria de
he
la
was
Corte
able to
Médica
learn
en
medicine in
1982.
many different places.
Profesor de semiología médica en el año 1937.
He
Acá no
was
se ve, lo siento,
a
pero era
professor
profesor titular de
of
semiología.
the
Y
extraordinary
este
pathology
hombre formó una
chair
tradición de
in
un hospital que se está
1932.
cayendo a pedazos,
He
está
was
corriendo
the
una-
head
pero que se
professor
mantiene
of
por
medical
esa
semiology
tradición.
in
El Hospital
1937.
del Salvador es el hospital del doctor Alessandri. Las salas tienen
The
nombre de, como vamos a ver,
Hospital of Del Salvador in
grandes
Santiago
internistas
is
que
Dr.
Dr.
Hernán
Lucho.
Alessandri's Hospital.
Era un honor estar haciendo sala en ese hospital.
Rooms
Y
are
acá
named
en el hospital
after
estar en
him.
sala era un castigo.
It was an honor
Sí, eso es verdad. Bueno,
to be doing
décadas
internships in
después, ¿no es
this
cierto?
hospital.
La cátedra y del servicio de medicina destacaron, se convirtieron en un modelo
In the
para el
following
desarrollo de la
decades,
salud en
the
nuestro país.
chair and
está con algunos de
medicine
sus,
service of the
¿cómo se
hospital
llama?
del Salvador
De personas que
became
formó, ahí está el doctor Lucho, ¿no es
an
cierto? Y acá
assistential
tienen ustedes algunos de los directores de la
teaching
Sociedad
model.
Médica de Santiago y como ven, y todos estos fueron
These are
discípulos del doctor
some
Hernán
of the
Alessandro
disciples
Rodríguez.
of Hernán
Ya, y este
Alessandri,
servicio clínico de gran disciplina médica, el que salud entendía
which
como
were
el
part of
cumplimiento
a clinical
riguroso
service
y
of
oportuno
great
de
medical
las tareas
discipline,
asistenciales y docentes que se le asignaban, pues ser funcionarios
in
del
which
Servicio Nacional
the
de Salud, de la
timely
Universidad
and
de Chile, que
rigorous
conversaba con el doctor Emilio Rossi,
assistential
presidente de la
and
Academia
teaching
Chilena,
tasks
que ocupó
were
el
fulfilled.
sillón que ocupaba el doctor Alessandri, y para él era un tremendo honor, y decía que en su servicio no se sabía quién era
For
el
Dr.
hospital y quién era
Alessandri,
la universidad.
it was a great honor
Porque
that
ambos
no
hacían
one
la
in
misma
his
labor.
service knew who he was precisely,
Bueno, y
because
eso
they
quiere decir un
all
poco cuando llegué acá, creían que
met
era yo
with
del
the
hospital, no era
with
de
the
la
high
universidad.
expectations.
El problema es que con el sueldo de la universidad no alcanzaba para muchas cosas, entre ellos arreglarme los dientes porque se me fracturó una muela cuando ¿ya? No, no está, es una cuestión increíble. Y gracias al servicio
Some
de
of
salud
the
que me contrató.
Yeah, he told an anecdote
Y en la
about
cátedra del doctor Alessandro
the university salary.
De aquí viene historia. Fíjense,
Okay,
2
so
semestres en el
more
tercer año de
history.
la carrera. 4 horas diarias de
Dr.
actividad
Alessandri
práctica en las salas de
highlighted the
carácter
importance of
tutorial.
medical semiology and implemented 2 semesters
Eso es
in
lo
the
que
third
hizo
year
grande a la
of the
medicina
program.
chilena, sobre todo en el área de la medicina de
This
adultos.
was
Y eso es súper
what
importante
these
tenerlo en
were the
cuenta.
doings
Por
of
eso
a
vuelvo a
great
enfatizar.
exponent
modelo
of
funcionó
Chilean
y debe
history,
volver a
of Chilean
funcionar.
medical history. That model worked
Un
and
docente
should
con
work
45
again.
alumnos y luego 45 minutos adicionales de exposiciones teóricas.
He had
por
one
eso,
teacher
la
with
gente
4 or
que
5
venía a
students
Finlandia,
and then
yo
implemented
me formé
45 extra
con el
minutes
profesor
of
Alessandri o en la cátedra del
theoretical
doctor
expositions
Alessandri.
and had 4 daily hours of practical activity
Veamos ahora lo que está pasando ahora. La otra gran escuela de medicina
as
en Chile,
part of his
¿cierto?
teaching.
Es la Pontificia Universidad Católica, pero aquí tengo que decir,
Now,
felicitar a los colegas
I
que
want
están
to
a cargo de la
talk
beca,
about the
que
other great school
nuestros
of
becados,
medicine,
puede llamarlo, tuvieron una
the
gran
Catholic
participación
University
en el
of
Congreso
Chile.
chileno de medicina interna, que entiendo que ocuparon el tercer lugar y le ganaron la mayor parte de las cédulas a Chile y le ganaron a la Pontificia Universidad Católica. Así que muy bien. Bueno. Bien. Este curso se aprende formalmente en el curso integrado de clínica 2 para alumnos de tercer año. Este curso incluye un programa de clase electiva, ¿no es cierto? Talleres prácticos,
Okay, so
físicos,
at the
fantomas,
course
lo que
of
sea el
the
doctor
Catholic
Gajardo,
University in
recursos
Chile
interactivos como este que está acá.
includes
Que un déficit en nuestro grupo, probablemente nunca le
practical
explicamos bien una radiografía
workshops,
tórax en tercer año a nuestros enfermos. O yo por lo menos no lo
a
hice.
physical
Adecuadamente.
exam
Además de actividades prácticas hospitalarias con pacientes reales.
with phantom and resources and mainly
Los alumnos también son divididos
practical
en grupos de
activities
5 o 6
with real
personas, los cuales
patients.
rotan tanto por actividades prácticas hospitalarias como por talleres de semiología presenciales con
The
simulación a cargo de un
students
tutor,
are divided
realizándose
in
este
groups of
último
5
año
to
por
6
semana
people,
hasta completar
which
un total de
rotate
14 talleres, que es más completo que lo que tenemos nosotros,
for
porque
practical
es más sistemático,
activities.
incluye una serie, ¿no es cierto?, cardíaco, pulmonar, urológico, dermatológico, neurológico, etc. Y, vuelvo a insistir, además tiene
I want to
la
insist upon
posibilidad
this.
de utilizar en línea
We have the
uno como semiólogo
it has
sistemas
the
de
possibility
simulación que van retroalimentando al alumno
of
y
the
facilitan, ¿no es
use
cierto?, la
of online
adquisición de conocimiento. De
simulators
manera que
that
estamos
give
atrasados.
feedback to the students.
Cuando yo estudié semiología,
When I studied semiology,
soy el profesor Ortiz me enseñó semiología,
Professor
yo me acuerdo
Ortiz
todavía,
taught this, I remember.
él se paró, nos saludó
Stood
y
up,
nos dijo: yo soy
he
gastroenterólogo,
said hi, and he said
Fíjense en
he
ese
was
tema,
a
que les voy a tener que hacer una
gastroenterologist.
clase de semiología, ojo, porque no conseguía nadie que me hiciera esta
But
clase.
I will have
Y
to
no hizo una
teach
excelente
semiology
clase
because I
de
have no
semiología.
one to do this. And he thought it
Eh,
great.
Se usaba
because
este libro, el manual de semiología del doctor Santiago Soto Dorado, extraordinario. Habían clases teóricas, eran muy completas, y 2 prácticas semanales con algunos seminarios, y había una parte en que uno rotaba con especialistas, es decir, iba con el doctor, por ejemplo, Bermúdez, y tenía un sistema en que todos ocultábamos la estenosis mitral de un enfermo, o la insuficiencia aórtica, etcétera, etcétera. Teníamos clases con los gastroenterólogos, ¿no es cierto? Eran otros tiempos también, había otra patología, veíamos a los pacientes con ascitis y dominábamos al revés de derecho la fisiopatología, la semiología, ¿no es cierto?, de ese tipo de enfermos. En broncopulmonar, obviamente que teníamos pacientes con neumonías neumocócicas y teníamos los síndromes de condensación y escuchábamos en forma muy frecuente soplos tubarios, que ahora en la actualidad casi no se escucha. Y lo otro, que no era un ramo tan fácil, había un examen práctico, además, que era con pacientes, y obviamente había un grado no menor, como todo en la vida, de azar. Entonces de repente le tocaba a un alumno un paciente mucho más complejo que otro. O sea, no era lo mismo un paciente que tenía una neumonía neumocócica, de todo desgarro, puntada de costado, fiebre, escalofríos, versus un paciente que tuvo un accidente vascular y estaba bastante secuelado. ¿Ya? Entonces siempre en la vida, lamentablemente, hay un grado de azar. Ahora tenemos clases teóricas, son bastante completas, tenemos un excelente libro, este libro muy completo. Una práctica semanal con tutor de 90 minutos aproximadamente, pero podía prolongarse sin problema 2 horas. Reforzamientos con alumnos ayudantes, pero las grandes limitantes ya fueron señaladas, ¿no es cierto? Hospital público no universitario, por tanto hay una limitación tremenda al acceso a nuestros estudiantes, y hay una obsesión en campos clínicos, ¿no es cierto?, por hacer las cosas lo más difícil posible para los estudiantes y para nosotros. ¿Ya? Me llama mucho la atención el celo profesional de estas personas, siendo que para otras cosas, un caso. Pero bueno, es parte de la cultura chilena. A las 11 de la mañana habían algunos colegas que desaparecían del hospital, pero nada. Pero para campos clínicos viejos estaban en forma perentoria controlando todo. Pero bueno, ya, aquí hay una limitación fundamental para muchas nuevas universidades en nuestro país. ¿Ya? Variabilidad interdocente, que lo señaló el doctor ya. Obviamente hay gente que está más o menos motivada. Yo traté de hacer lo que pude. El mejor fantoma que usaron mis alumnos fui yo mismo. Me examinaron al revés y al derecho. Por pudor no me hicieron tacto rectal, pero bueno. Son bromas, doctor. Somos latinos. Pero aquí hay otro elemento que es súper importante y que bueno, yo los felicito, perdón que me esté explayando largo, pero créanme que tuve que trabajar para probar esto. Y es el convencimiento que tenemos nosotros acaso sirve la semiología. ¿Ya? Entonces, como por suerte hay un nuevo énfasis en el servicio de medicina, yo creo que está funcionando muy bien. Tengo mis dudas sobre otros servicios, particularmente quirúrgicos, pero medicina está funcionando muy bien. Sergio Mella está. Se me fue la onda por hablar de más. Hay un reencantamiento, ¿no es cierto?, con el internista general que está a cargo de una sala, lo que es fantástico. Yo creo que hay que reencantarnos entre nosotros para que además el docente de la U se reencante con la semiología. Yo creo que en ese momento vamos a volver a marcar
And here we would be making an important change in the way we teach our students.
Autor norteamericano,
There is
de la costa oeste, probablemente lo ubique el doctor y sobre, ¿no es cierto?, los problemas del examen físico, está publicado en Journal, American Journal, Medicine, y hizo un cuestionario a 5.000 colegas y solamente 263 respondieron, pero algunos de los que más se repetían con mayor frecuencia.
Some of the topics that were recurrent. I'm sorry you are not able to see this, but it's neurology.
El examen físico de ausencia, ¿no es cierto?, del examen abdominal,
the lack
tumores,
of
hasta
abdominal
peritonitis, ausencia del
examination,
examen físico a nivel
the lack of a physical exam.
Por alto, no te preocupes, amigo. Lesiones hasta de software, ¿ya?
Okay, do not worry, I will continue with the presentation.
De lo que yo les señalaba, ¿no es cierto?
Here are some examples of what I mentioned.
O sea, podrían haber pacientes que tenían alguna fractura.
So we had some, for example, patients who had fractures,
ausencia de pulso,
lack of
etcétera.
pulse, etc.
Lo que vuelve a señalar, y este es un médico por lo que yo pude
What
ver,
he
que tiene
mentions
una línea muy
again,
importante de
and he is a
pensamiento,
doctor
a
who
pesar
has
de,
an
¿no es
important
cierto?, la
line of
importancia de
thought
la tecnología, es sobre la revitalización
in
del
spite of
examen
the use of
médico
technology,
junto a la cama del enfermo.
which is
Y
the
aquí, ¿no es cierto?, nos
reuse
daba algunas
of
claves de algunos ejemplos.
bedside physical examination of patients.
Ya lo nombró, ¿cómo se llama? El doctor Gajardo, la cantidad
Dr.
de
Gajardo
información acá.
already
Les
mentioned
dejo
the
esto
amount
de
of
dominio público,
information
algunas citas que me parecen muy interesantes
we have,
de,
and
en literatura,
here you have some
en inglés, ¿no es cierto?, sobre la importancia de la semiología.
citations
Acá
about the
tienen,
importance of
acá
semiology.
tienen, ¿no es cierto?, otra opinión de este
Here you have the
que además
opinion
es
of this
escritor,
other
muy
author.
completo, un escritor,
He is
tiene,
also a writer,
un área clínica, ¿no es cierto?, en el área de examen físico y
clinical
desarrolla
settings,
también,
physical
se ha desarrollado como
exams,
escritor de muy buen nivel.
and
Y aquí enseñar una cosa que es súper importante.
he also writes. So I would like to mention here, which I think it is important, that physical examination, anamnesis, semiology have like a ritual importance for patients, which is important in neurobiology. Patients feel better when doctors ask them how they are doing, how they are feeling. And when he examines him carefully, that patient feels more welcome and better in their neurobiology when no one is
I mean, instead of no one examining. And also, as Dr. Gajardo said, how do you learn medicine, most of all in a country like the one we have? Here, that was characterized by the absence of industrial revolution. The first colonizers in Chile did not know how to write or read. Those colonizers in the US at least knew how to write. And they started in Great Britain, which is something that is heavy and will be heavy over time. So it is something that we do here on the bedside. Thank you very much.
We thank Dr. Sergio Mella for his presentation, and to finish up this first part of our seminar, we invite you to enjoy our coffee break, and we will meet again at 10:30 to resume our seminar.
Tomando nuestra jornada con el segundo módulo dedicado al razonamiento clínico. Es un placer presentar al doctor Hernán Carrillo, profesor asistente de la Facultad de Medicina de la Universidad de Concepción. El doctor Carrillo nos hablará sobre razonamiento clínico en el proceso diagnóstico en medicina interna. Recibimos con un fuerte abrazo al doctor.
Súper, muchas gracias por la presentación. Estoy muy contento de este momento. Ha sido un primer bloque bastante intenso, con miradas muy profundas y con mucha experiencia respecto a lo que es la educación médica, sobre todo en semiología, así que espero poder sinceramente aportarles también luces sobre la etapa que tiene que ver con el razonamiento clínico. Primero contarles que cuando hace un tiempo nos propusimos hacer un electivo de razonamiento clínico, un grupo de personas entusiasmadas, y tal como el doctor Gajardo y el doctor Mella dijeron, con ganas de cambiar las cosas, nos juntamos y tuvimos este sueño de, algo está pasando con el razonamiento clínico en el mundo y nosotros tenemos que tomar ese guante
and take it to reality with our students, because this seems to be a missing link within the distance of semiology and internal medicine. So we now welcome Cata Saldivia, who's here with us today, Junji, who is a brilliant student, Gabriel Martinez, whom a lot of you may know because he's very well known around here, Susana Reyes, who was back then in her last year as an intern, and Dr. Cristian Perez of Medical Education, who has helped us greatly to get this elective to a next degree of maturity that sometimes us clinical professionals don't have as ingrained. And this first year was very hard work, and we strive to have a clear path that was something new for students, and that you could that you as students could enjoy this elective and find it interesting and attractive. That wasn't an obligation, but something that you were willing to do. We really worked hard for that, and the first course we had, which was the second semester of last year, was an incredible experience. 24 students who hopped on this boat with full of expectations and hopes and a wish to learn, thirsty for learning how to apply their knowledge of fundamental sciences with their patients. Today, our team has been even further consolidated. Some of them have took new responsibilities. Junji is in his last semester, so he has another elective. Kata has stayed with us and has been balancing the last year of her program and doing this service, which isn't a part of what she needs to graduate, but she's very committed to it. Gabo has also remained with us. He's always there. Cristian Perez of Medical Education is also with us, and we have welcomed two new colleagues, Dr. Ricardo Cartes, who is a researcher in the area of health sciences and has allowed us to upgrade our level of research question and take them to reality of scientific dissemination, and Nicolas Burgos, who has been presenting this seminar today, and he's a great example of what has been going on with this elective. He came as a student in the second semester of last year, and he stood out because of his love and dedication to internal medicine. He then took an elective with us over the summer, when we all want to be resting under the sun in the swimming pool. But Nicolas dared to stay with us over the summer, working side by side with internal medicine in Hospital Las Higueras. And then Nicolas is turned into an assistant of the elective. And so this is an incarnation of the effort and the dreams that we have put into this elective, so that we can develop our talents and you can have a narrative of medicine that makes sense to you, such as Dr. Mella and Gajardo said. They put emphasis on highlighting the complexities of the 21st century. I think it is hard to live in 2024. It is hard to deal with the speed of technology, the artificial intelligence that is accessible to everyone now, the different insights of those who are older than us, to deal with the pressure of the world. We are very stressed and we have to comply to everything. So this is a very challenging time, and we think that a clinical reasoning for the medical student experience is pivotal because it allows us to put together, to balance the complexity of living in 2024 and technology. A brief context of why we came to need this elective. I'm not going to repeat this again. You know this already, but at the start of the 20th century, you could identify a line of security in the USA. This ended in the 1980s when some students were able to detect the mistakes that happen during a hospitalization, and this was this ended in the 90s with a line of study, and this also ended in an article that I'm always quoting, even though maybe Dr. Rodman will later say that this article had a series of weaknesses, and this case was highly advertised in publishing, because when if I tell you that cancer is the first cause of death, then heart disease, and then medical negligence, we are in trouble. So, my dear Dr. Rodman, I want to keep this slide here because I think it's important to point out that how important this issue is. So, with that context, I want to ask you, what are we talking about when we talk about the diagnostic process? This is an article from 2015, which is basically the map of the diagnosis process that is the official when we want to talk about this and take it as a starting point. So, if you see, this starts from when the patient begins to feel some sensation, be it bodily or spiritual sensation, which is abnormal to their daily life, and comes to a point where it needs attention. So, from this first stage, you can get some a group of difficulties that stem from political to structural struggles of society, but at some point this patient decides to go to a medical appointment, a private medical appointment, or and this big circle that you see is the interaction between physician and patient. And we have, in the circle, there is classic semiology, analysis, proposing a hypothesis. All of this is in the cycle that Dr. Gajardo wonderfully exposed earlier. And then communication of the diagnosis, as Dr. Mella said, the communication of the diagnosis is an event in and of itself. The treatment and the following of this process is in the map of the diagnostic process so that they inform the process. So, if I propose a treatment and in 4 days the patient is not doing better, this informs a mistake in the process. So, what do we have in the university? Currently we have a subject of semiology, which is teaching us how to take this information, and then we get from there to the subjects of internal medicine 1 and 2. So, the relation to all of us who have the mental whiplash is great, because we go from being taught to conduct the interview, to get information, and then right away we have the nosological entities. So there's a gap there. What is this gap? The current structure of the syllabus only encompasses the obtaining of the information, which is just 1/3 of the circle, but the integration of analysis and proposal of diagnosis in terms of a methodological structure are not part of this right now. Because semiology does in fact encompass these parts, but only in concerning the obtaining of the information, the gathering of information. So these other 2 points are not properly encompassed. So we got to this elective, which we named Clinical Reasoning in the process of diagnosis in internal medicine. I wanted the title to be catcher, but Dr. Perez taught me that every subject's name has to reflect the contents of it. So we can call it a clinical reasoning for short. When we start the elective, we wondered if we were alone in this. But we then found out that this is a line that is being reinforced at a global level. This is a website that is called Raciocinio Clínico, that I highly recommend. There are the clinical problem solvers that we love, and we are big fans of them, as everyone who has taken classes with us know. They hold a free Zoom session in which you can listen to a discussion of a clinical case by experts, held by experts. We have participated twice in this clinical problem solver session. We are very happy about that. Dr. Rivera was a great presenter during her internship. We have the podcast of Applied Internal Medicine, which is an effort of Universidad de Chile, as Dr. Mella highlighted. It's on Spotify, and they discuss cases from the perspective of diagnosis. And of course, one of the most important podcasts in this area, which I don't know if you are familiar with, but it's by Dr. Rodman. Hopefully one day we can have him with us. Oh, there he is. And sometimes people and teams, we have been motivated by this because we want to show students that we are not alone in this. And all of a sudden, we started getting greetings.
I'm so excited to hear from Hernán that you all are starting clinical reasoning curriculum. That's the single most important topic in medicine, truly. What Hernán is equipping you with is the ability to think critically, carefully, and to get your patients the single most important thing that they're hoping for, an answer as to what's going on.
Él es Ravi Geja, es médico
He is
internista
Ravi
y
Geja,
emergenciólogo
internal
de la Universidad de
physician
California,
of the University of California, one of the founders of Clinical Problem Solvers. He's really clever. He is the mathematician of diagnosis because the management he has on probability rates. Just to get to, from this gathering of information to the right mark, it's impressive.
¿Viste que mi doctor Mella tenía razón?
You see that Dr. Mella had right?
Vamos a hacer el truco del golpecito.
We are going to do this trick of hitting this.
Hola, ¿qué tal?
No, ¿dónde le apreté mucho?
No, I think I did it too hard. I wanted to say hi and congratulate you for talking about this topic of clinical reasoning in Chile. I think it's nice to see that this topic is growing in Latin America and you are the leaders of this. So please know that that is our second home and we will always be your home.
Ella es MJ
She
alemán,
is MJ, Maria Jimena Alemán. She is from Guatemala. She started as a student, being a part of clinical problem solvers, and they took her, they offered her opportunities. She has now a scholarship in a wonderful center. She has a set of publications in important journals, and she is really nice, simple. She's from Guatemala, and she has achieved a huge importance in changing the things that are going on, and just because of her motivation to change things.
Hola, ¿cómo están?
Hey, my name is Francisco Cortés, and I'm an internal physician of the San Borja Hospital, and I also work here at the University of Chile. I am also part of the internal physicians of the Hospital San Borja Arriarán. We are developing a podcast on internal medicine, and I am reaching out to you to say hi and to motivate you to develop this elective of clinical reasoning that you are doing in your first year. Why is this important? Because it helps us to integrate all the main subjects, and it is all the cognitive process taken to something more concrete, side by side with the patients. This is not so established in the syllabus, and it is really good that you are taking these courses to integrate this, which is really important in internal medicine. So a lot of success, and I would also like to say that you can follow this podcast of internal medicine. We have some chapters in social media, especially on Spotify. Please follow us to listen those good clinical cases. Bye, have a good day.
Bien, o sea, no estamos solos ni en
So we are not alone,
ni en América,
not in
ni en Iberoamérica,
Latin America,
y por supuesto,
Iberoamerica or Chile, and of course Dr. Rodman, who
para que podamos disfrutarlo.
is talking next, so that we can
Así
hear
que
him.
esto es una realidad
So
que
this is a
nos
reality
acompaña, y
that
los invito
is
a
by our side,
revisar
and
todos
I
esos
invite you
recursos.
to research on all of these
Nos fuimos a la parte
resources.
media fome de hacer una asignatura, que hay que
When we
sentarse a
went to
escribir
the
un
boring
sílabo
part
que tiene un formato
of
bien así,
presenting a new
antiguo.
subject, we had to
Entonces, nos
write all of
propusimos
these
estos
things,
resultados de
so we
aprendizaje, no me
wanted
voy a
to
detener
add
acá.
these learning results.
Pero
I'm
sí,
not going to
acá
talk
quiero hacer
about
una
them,
pausa.
but I would
Y
like to
estos
pause here,
contenidos, y fíjense
which
que
are the
no
contents.
son contenidos que
These
estemos
are not
formalmente
contents
abordando
that we are
en
taking
la carrera.
on the career, for example, a differential diagnosis on diseases, which is something that Dr. Santiago Soto developed and has influenced the semiology here in Concepción, estimation of probabilities of a level, which is not only our intuition and diagnostical planification. And as I said, the effort of this was to create a community. We started with a WhatsApp group, adding students who coordinate this. It is an active group where we are sharing ideas, things that we experience, what makes us sad. This year we have another WhatsApp group, so we can be discussing things there and sharing. Now I would like to talk about something that distinguishes clinical reasoning from other types of reasoning. I won't talk deeply about what is clinical reasoning so that Dr. Rodman can talk about this, but I would like to tell you, I would like to begin with this.
When people source-orient data, you appear very unscientific. But it's even worse than appearance. It's the very essence of the practice of medicine. This is not an idle discussion of little technical bookkeeping details. The practice of medicine is the way you handle data and think with it. And the way you handle it determines the way you think. Once you get over a period of time with multiple variables, the very structure of the data determines the quality of the output. And this is what's so hard for medicine to accept.
Why is it so hard for medicine to accept this? What? That we can gather information and be excellent in semiology when reaching that anamnesis and physical exam in general and bisections is something that requires depth, which is how do I make an order in this information to have a diagnosis. Why is this so important to medicine? Because it has a lot to do with social sciences more than with biomedical sciences. So there is a distinction in here which we have discussed with Dr. Rodman. We need to add a higher amount of social sciences in our formation. Science, philosophy, anthropology, sociology, etc. Logical, Aristotelic logic. It is hard. But in the end, when gathering all of these and having all of this information in front of me, that is one step by itself. And the first thing that we have to distinguish within this reasoning is that usually how the laboratory scientific method is brought to us is something that Flexner tried to brought to us during the 20th century when the medicine school in the US asked Flexner, who was not a physician, he was a professor, to develop a report, and he said that what they needed to do was to close 40% of them, and the study was going to be basic sciences, because they needed that the physicians had this core, then preclinical, a little bit of clinical skills, as they call it in the US, and the practices of their specialty. So what we have received with that formation, meaning all of the analysis that we do, is either deductive or inductive. I'm not going to talk about these philosophical topic, but when we are in front of the patient, that logic that we have been taught does not work. Is that because what we do in front of the patient is that we perform an abductive analysis, and This means that with any doses of information, I am able to administer uncertainty in such a way to propose something possible with that information. I said that a little bit hard to be elegant, but I will say that simpler in the course. And linked with that abductive reasoning, meaning to add this uncertainty, independent of the amount of information, is pragmatical, and it is different to be in the scientific method of laboratories. Pragmatic means that I need the information and add a tag because I need to be doing things right away. I need to make decisions, and those decisions are based historically, culturally, in a certain moment. So it's not the same that what scientists do in a laboratory. This is the real world, and in the real world, information is chaotic, and I need something that allows me to deal with that chaos, where I don't need all of that chaos and information of the patient. I need good information, quality information, but I will be able to deal with the real world because I will be able to take this uncertainty and apply it to the real world. This is really important. Diagnostic reasoning is different to therapeutic reasoning. This is a taxonomical exercise. I have information and a tag. I classify. So diagnostical reasoning has a right response. The patient is either in shock or not, but we cannot talk about Schrodinger's cat here. However, therapeutic reasoning has not a right response. It's always something about shared decisions. It is situated in relationship with the resources that I have. Therefore, treating TB with antibiotics in Africa is different of what I am able to do in Chile, and both things can be right, because therapies are shared decisions and are based historically. They interact with each other. There are several factors on this. Therefore, we are able to perform diagnosis only by receiving information. Yes, I am able during a class, if you tell me about a case, I am able to do a diagnosis. Am I able to offer therapy? No. I can tell you in pneumonia acquired in the community of a patient that complies with ambulatory characteristics is able to be cured by oral medicine, but when I'm with Mr. Juan, he has a dog, 2 girls, one of those girls is dependent on medicine, he's not working, he doesn't have accessibility to certain things, he doesn't know how to read, he doesn't know how to take his medicine. In the SESFAM, they don't have more amoxicillin, so I might recommend something that is proved for a certain disease, but when we are doing therapy, we are in front of a person, and that is harder.
I'm not going to stop in this in the system 1 or intuitive system. So thanks, Shakira, for that song. And the second system, which is the analytical system, in which one analyzes in detail. And the question is, due to this is being discussed with Dr. Rodman, how do we do this system too. How must we think for this diagnostic? And we have been proposing this scheme, which doesn't have any special science. It is very, very simple. I am very sure that Dr. Bello are looking at this, but this is what we do. But when we show this to students, that there is a step-by-step system that we can follow, this is the simplified version of the clinical reasoning. Here you have the patient with a question, with a clinical history. I convert it into a syndrome, and for sure I am including many studies in one. And when I ask students, where is it in the community? Well, it is here. No, it's not. It's not there, because pneumonia acquired in the community, it's a...
But when we identify that, and we said that we have pneumonia by Staphylococcus aureus, we are talking about different types of therapy when we have pneumonia by mycoplasma. So when we are in nosological therapy, we are talking about symptoms. And that is the point of going to Medicine 1. They explain the information, but not how we go from this to that other point. And gravity, this is something that we name when we ask ourselves the security, what Dr. Mella said about airports. My patient severely ill. What does that mean? So we have heterogeneous responses. Do you see we have done with internal medicine and eternal medicine by ourselves? Because what is the complaint of the students? It is too bright, has not limits, it is everything. And when we have such a concept, it's the same of saying we have nothing. We have to put a definition into things. So when you are going to urgencies, you have to open up the curtain and anticipate of the worst that might happen, which is the patient being dead. And what is the definition of that? And then we have crickets.
So what are the diagnosis criteria for a patient's death? We begin to discover there are classic criteria related to cardiology and respiratory issues, and then we find out there are different criteria for patients who are warm, who and who have different characteristics. So I can say that my differential diagnosis is that the patient is dead. So it's not that crazy to have written that down, even if it can still be reversed. So the medical team doesn't yell out death. They yell arrest, a cardiac arrest, because the dead patient doesn't beat, his heart doesn't beat, he's not breathing. What is the difference? One can be reversed and the other can't. So is every arrest the same? No, because as we were taught is that the cardiogenic arrest, imagine you have a 55 obese-year-old man who passes out in the middle of the street, and we have these we know that we have to to take him to the cardiac unit. But what about a pregnancy arrest? It is another syndromatic effect. What if I tell you about an arrest in an abdominal trauma? if we have this case, the mortality is about 99%. So maybe you could save the massage. And what if I tell you about an intra-hospital arrest, or shock, or dysfunction, organic dysfunction, or red flag? I'm not going to go deep into this to save time, but this model of gravity and probability has worked for us really well. The probability we should call the abductive branch, because here we tackle uncertainty, but it sounds, but we're going to keep the name probability. So how can we assess this uncertainty? We have the scripts of illness, which is a very interesting theory of learning. The theories of illness that Dr. Santiago Soto taught us, the anatomic systems, which has 5 points that are developed by Dr. Ortiz in his classic presentation. The 5 point of anamnesic proximity,
revisión del sistema afectado, revisión de los otros sistemas y compromiso del estado general. ¿Y eso para qué es?
We have the revision.
Lo que busca es determinar cuál es la estructura.
What we strive for is how to assess the anatomic structure. If I tell, if I say that I have an acute pain accompanied by a cough and fever, and it is deepened by breathing, and it's even difficult breathing, is called pleuritic pain, and the value of that is that the pleura is committed. So I invite you all to have an anatomic vision of the diagnosis process, and this is highly valued by students because they say, wow, now I can actually put to use all of the things that I learned in the first year. So clinical reasoning has a place that complements semiology and has its main focus on communication and gathering of information. Nowadays, clinical reasoning needs to be a step in and of itself, and there's a lot of science behind how we think or how we must train our thinking process to get to a good diagnosis. This is the end of my presentation. I hope you enjoyed it, and thank you very much.
Agradecemos al Dr. Carrillo por su excelente presentación.
Thank you, Dr. Carrillo, for your excellent presentation. Next, we're going to project our QR code so that you can ask your questions through this medium.
Ya el QR va a pasar por cada puesto más o menos para que puedan, ya que no lo podemos proyectar. Ya. A continuación nos honra la presencia del doctor Adam Rodman. El profesor Rodman, actualmente profesor asistente de la Escuela de Medicina de Harvard y miembro del equipo de médico de Beth Israel Deaconess Medical Center, es un líder reconocido en el ámbito de la educación médica digital.
He's a recognized person in the clinical reasoning ambit. His development to innovations in the curriculum that highlight him as a prominent figure in in the current medical environment. He is now the co-director of IMED, where he has transformed medical education, incorporating new tools, innovative tools, and has gathered experts of the whole from the whole world, and have implemented scoop dart state-of-the-art tools, and he has been awarded many recognitions and awards because of all his work and innovation. He has also been awarded with the Harvard Medical School Mentorship Award, and highlighting his commitment to the new generations of doctors. He has had several papers published in important magazines, including his contributions to the field of artificial intelligence in the current medical landscape. His presentation is titled "Through Second Opinions through Artificial Intelligence." So we warmly welcome Dr. Adam Rodman. Hola a todos. Mi nombre es Adam Rodman. Soy un
how people think. So I study clinical reasoning. One of the ironic things is that I am not an artificial intelligence researcher. My focus has always been on what happens up here. And one of the major themes today has been the effect of technology on semiology. So how technology has changed our approach. As has been said, we actually don't say semiology in the Anglo-Saxon world. Semiology, however, is a very old word. Semiotics, as someone who loves history, I'm going to say semiology. My focus of my research is not necessarily on semiology, but on clinical reasoning and how technology changes what happens up here. So this is what I'm going to talk about today. I'm very excited because I'm going to be joined by Dr. Carrillo for a part. So first, we are going to talk about our current understanding of clinical reasoning. Dr. Carrillo gave a wonderful overview on the education of clinical reasoning. I am going to talk about some of the research from a cognitive psychological perspective of what actually happens when we see patients. And then we're going to talk about why this matters. Dr. Carrillo already mentioned medical errors, diagnostic errors, which are one of the big reasons we care deeply about clinical reasoning. The next reason might be that computers are going to be increasingly doing that, so how do we work with them? And then I don't want to just talk to you. I want to show you how reasoning is affected by technology. So I am going to be joined again by Dr. Carrillo solving a mystery case live. He has not seen it before. And we are going to also use an artificial technology during the case so we can both compare and contrast the nature of human and machine clinical reasoning. The reason that I want to show this demonstration is we are then going to talk about the evidence. In the last 2 years, and I should say this is an old field, this field actually stretches back to 1959, but in the last 2 years there has been an explosion of both very exciting and very scary evidence. Medicine is changing rapidly to the point that I think a couple decades from now it's going to be unrecognizable from how it is today. And then I'm going to talk a little bit about my own research, which is a field called human-computer interaction. The question is not how do humans reason, it is not how do computers reason, but how do we reason together? What is, what can we do well together? What can we not do well together? And then to really kind of answer this question, well, what should we be learning in medical school? Okay, so we're going to start with a simple question. It's actually a very complicated question. What is diagnosis?
Dr. Carrillo showed an example from the National Academies of Medicine from the 2015 report of the diagnostic process. The short answer, though, is it's complicated. There's actually a wonderful study from about 15 years ago that took a number of experts in clinical reasoning and asked them, what does it mean to make a diagnosis? And they basically got 15 different answers. It is incredibly complicated, and I'm going to kind of explain why. So Dr. Carrillo mentioned at its most basic, diagnosis is a classification task. We have a nosology, so we have a classification scheme for disease, and what we have to do as physicians, as internists, is identify which of those diseases our patient has. And we use many different processes to do that. We use semiology. We take a clinical history. We order different diagnostic tests. And at the end, we hope that we can narrow it down to a single or multiple diseases, a differential diagnosis. Now, part of the process is that this is all mediated through the human mind. And I'm going to talk first about really the most revolutionary idea in clinical reasoning, what really started this field off, which is dual process theory. Dr. Carrillo, I'm both basically copying you, but to go off of Kahneman and Tversky, so in the 1970s, psychologists became aware that human beings actually have two different systems of clinical thought. We have our system one, that's our Homer Simpson here. System one is very fast, it is very efficient, it is based on shortcuts called heuristics. The classic example is everyone has driven home at some point. You've driven in a car, and you'll have these points where you just stop paying attention and 10 minutes can go by and you'll still have been driving. Why does that happen? There is a very fast, automated, efficient Mr. Spock over here is our system 2 thinking. System 2 is very slow, but it's also very deliberate, and it's acontextual. It is difficult to do system 2 thinking. When we talk about clinical reasoning, we're often talking about these system 2 processes. The classic studies from this come from the 1970s by Larry Elstein, actually at Harvard. Dr. Carrillo was talking about the abductive process. Abductivo, that word is used in Spanish. In English, we often talk about the hypothetico-deductive process, but they're the same thing. Imagine Sherlock Holmes. This is your classic example, or Dr. House from the TV show. The doctor is a detective who uses both inductive and deductive reasoning to solve problems. We collect information, make a differential, and then we test those different things on a differential as new information comes. So Dr. Elstein did some very famous experiments at Harvard in the late 1970s, where he sat down a group of medical students and he sat down a group of experienced attendings, and he gave them cases. What he found is that both the medical students and the attendings used the abductive process. Everyone acted like they were a detective. But what he found that was very curious, that didn't make a lot of sense to him, is even though both of them used the same appearance of reasoning, the attendings would only ask a few questions. They asked about a quarter of the questions of the medical students, and they were much more accurate in coming up with a diagnosis. So the medical students would ask many more questions in a hypothetical-deductive fashion, but come up with a less accurate answer. This was the first hint in the 1970s that something else was going on inside the human brain. And as we know now, this is the same image that Dr. Carrillo showed. What's happening is a very complex interplay between system 1 and system 2. So what happens inside the attending's brain, who has much more experience, is they have a much more refined system 1. So they are able to identify patterns much earlier in the presentation before switching into system 2 thinking to ask more focused questions. At some points, the attendings don't even use system 2. They may be able to get along just on system 1. Now, this is very theoretical. This image is very hard to understand, so I'm going to give a practical example from something that is called script theory. Script theory is an educational strategy that's based on dual process theory. So how do doctors know what diagnosis that a patient has? So we get knowledge from the world in many different ways. We go to medical school. One of the most important things that we do. We read journal articles, and then we see our patients and learn from our patients and get feedback. All of this information gets stored in our brain. how does the brain store knowledge? So if you go back into the early 20th century, the assumption was that we stored knowledge kind of like the Dewey Decimal System, like knowledge in a library. But we know now that that is not true. And doctors in particular store knowledge in something called scripts. What is a script? A script is an exemplar of a disease state. So for example, my script for pneumonia might say, okay, it affects both children through older adults. It's usually subacute in onset. There are usually low-grade fevers, respiratory symptoms, and then I have senses of will it respond to antibiotics, how does the patient look? What does their respiratory exam look like? What do they sound like on auscultation? And all of this information is stored in this automated illness script. Now, one of the points of script theory is that scripts don't exist in isolation. They exist in schemas in our brain, by which I will identify one disease by excluding other diseases. This is one for shock here. And of course, because this is a system one process, it's a shortcut process, there are many ways that human beings can go wrong. We can have personal biases. We can have systemic biases. We see this all the time in the hospital. I'm a general internist. I work in the clinics and the wards. I do not work in the emergency room. So my experience of a pneumonia and my scripts for a pneumonia are very different than an emergency room doctor who is seeing much sicker patients, right? Usually the patients that I see with pneumonia are, if they're seeing me in clinic, they're not that ill, whereas the script for someone who works in the emergency room, if you come to the emergency room, you're much sicker. So what happens when we see a patient? And everyone has this experience. So I'm sitting in clinic, a patient comes and see me. This woman says, I can't breathe, it started yesterday. I'm not even really having conscious thought. It's like when I'm on the highway and I stop paying attention when I'm driving. And in my head, I automatically convert these phrases into something called a problem representation. This activates the script in my head for something that I call acute dyspnea. And because this is acute dyspnea, I automatically activate a schema for how I think about people with shortness of breath. What happens? Well, it feeds back to my questions. So I'm not necessarily consciously going through a Sherlock Holmes process. And my next questions are going to be, well, have you been wheezing? Do you have a fever? Why? Because in my schema for acute dyspnea, I have a COPD exacerbation, an asthma exacerbation, a pulmonary embolism. And then I will, as I collect this information, I will further instantiate my problem representation. So now I have acute dyspnea with wheezing and without fever. And this process continues iteratively until I have a pretty good differential diagnosis. Now, what also can happen, of course, is that I can find something that doesn't fit. I can find something that confuses me. Something causes me to pause, and then I will switch into more system 2 thinking, where I may start to use inductive reasoning, so physiologic reasoning, where I may start to use probabilistic reasoning, looking at test characteristics, or many other forms of human reasoning. But in general, the way that we approach our patients mostly focuses on this system 1 process with these crossovers to system 2. So if we were to go back 10, 15 years ago, dual process theory was the most profound way we thought about clinical reasoning. However, psychologists have been busy really talking about other ways that humans reason, or that doctors, I should say, reason. So we have, of course, Homer Simpson here in his brain. But the reality is, think about your life on the wards. There's a lot of other things going on. So I use a pager in the United States. My pager goes off every 2 to 3 minutes. The hospital can be a very stressful environment. Sometimes it is 2 a.m. and I am only able to take care of patients because I have had 2 liters of coffee. I may not have slept very well, and there are many other colleagues that I interact with. I could be having a bad day. Maybe I got in a fight with my wife before I came to work. Maybe I'm having a wonderful day. And I can see the exact same patient, and if I see that patient at 10 a.m., I've had 2 cups of coffee, I'm having a great day, or I see that patient at 2 a.m., when I have been paged 10 times in the last 15 minutes, my mind is going to work differently. And this is the idea of ecological psychology. So dual process theory focuses only on the human mind. Ecological psychology posits that reasoning is a byproduct. Not only, it doesn't only exist in our mind, but it exists between the doctor and all of our surrounding context. Because of that, the surrounding context can have great differences in how we make decisions. There's also, and Dr. Carrillo talked about this briefly, situated cognition. So there are cultural differences and individual differences in clinical reasoning that are unique to a cultural setting or even unique to an individual. A classic example might be hantavirus. I have never taken care of a case of hantavirus in my life. I'm a decent doctor. My hair is gray. I've been practicing medicine for a very long time. If I saw a case of hantavirus, even seeing the same information, I would probably miss the diagnosis because that is not something that I am situated to. It is not part of my medical understanding of the world. Similarly, in New England, we have a disease called anaplasma, so ehrlichiosis, which you may learn about but will never see in Chile. It's very similar to malaria and how it presents. When I first started practicing medicine, I see it all the time, but when new doctors come to New England, they are not thinking about this otherwise very common disease. Now, the other thing that I should say is the way that we study clinical reasoning traditionally has focused only on an individual. That is not the reality of clinical medicine. Medicine in the year 2024 is about teamwork, and not only with other clinicians, but with other healthcare providers, including our pharmacists, including our nurses, and other professionals. And what's very interesting is the way that we are taught clinical reasoning is, if anyone has been in a clinical reasoning case, you have all the information given to you. It's like a mystery. It's like a legal case. The reality, though, is that the information that we use to make decisions is spread out over time. Sometimes it's spread out over years, multiple different people, and I think this is part of the key. It's often mediated by technology in a way that it was not in the past. So chart review is something that is very important, and the key for me making a diagnosis may have been a test that was done in the medical record 2 years ago. So this is the idea of distributed cognition, that clinical reasoning does not only exist in a human's mind, it doesn't only exist in our environment, but it is about the collaboration of multiple people over different times and different places. All right, so those are our psychological theories that are up to date, right? This is our current psychological understanding of how humans make, or how doctors make decisions. Why do we care? Dr. Carrillo talked about medical errors. Doctors make an unfortunately high number of diagnostic errors. This is from David Newman Toker's most recent study. It was just published earlier this year. This is in the US, but 800,000 people die or are disabled because of misdiagnosis. The stat that he pulled out is 15 diseases account for half of all serious harms. The actual statistic is 4 diseases account for 40% of the harms. And these are diseases such as heart attacks. They're not difficult diseases to make. So misdiagnosis, it's not the like lupus nephritis that is being misdiagnosed, though I'm sure lupus nephritis is being misdiagnosed. It's acute MI. It's cancer that is being misdiagnosed. Diagnostic errors are very high stake. Now, one of the complaints to all the error literature is that, sure, there are diagnostic errors. Nobody says that there are not diagnostic errors, but are they because of the human mind? There are many systems issues that can cause diagnostic errors. This is a wonderful study by Andy Auerbach, a hospitalist. I think Hernán, Dr. Carrillo knows him from the Home Run study, that looked at patients who were admitted to the hospital and they were correctly triaged. So they were not super sick patients. And then they got worse and went to the ICU. And they did a retrospective chart review. I was part of this study. And they found that defects in human cognition were by far the largest contributor, and that the number 2 issue was testing errors, which is another defect in human cognition. So we have known this for 20 or 30 years. It's just more information confirming that defects in human cognition are a large part of what drives diagnostic errors. Now, you might say this is great because we can improve human cognition. If we can identify that a large cause of human errors and harm is problem in decision making and cognition, are there not things that we can do to make people better? And the answer has been, well, we hope so. So there have been 3 overall categories. This is what everyone in this room is doing. Everyone in this room is taking part in learning about human cognition. The 3 big strategies have been education about cognitive biases. So if you ever learn about anchoring bias or recency bias, the idea here is that by teaching you about these biases, we will improve your ability to identify biases in the future. Number 2 is de-biasing strategies. The most famous thing here is reflection. We know, for example, that one of the best ways we make doctors better is by having them follow up on their own patients and reflect about what went well or what didn't go well. And then the 3rd category is computers, artificial intelligence. Now, the unfortunate fact of this is that none, well, other than the 3rd, number 1 and number 2, even when they work experimentally, don't seem to work in the real world. And I think everybody knows the reason. It would be wonderful if we had a health system that allowed us time to reflect on how our patients did and to learn from that. Chile is very similar to the United States in this fashion. We see there is so much pressure to see more patients. When I am in clinic, I see a patient every 15 to 20 minutes. When I am in the hospital, I have to see between 15 and 20 patients. It is very difficult to carve out time. And in Chile, I think it is in the same as the US, after one of my patients discharges, unless I specifically seek them out, I very rarely learn about how they do. Now, this is different in my clinic. Being in the clinic keeps you very honest because you often learn exactly what you're good at and bad at. Of course, if you do a bad job, often the patients don't come back to you. So even in that, you don't get a lot of calibration here. So this brings us to artificial intelligence as a 3rd. As a reasoning researcher, one thing that I have to tell everybody here is that the study of AI is very old. There is a tendency, especially among people in Silicon Valley who want to make a lot of money, that AI is a new technology. We have been, this is actually the oldest quote that I have ever found about artificial intelligence. And if you look at the date, it's from the playwright, the English playwright Bernard Shaw in 1918. So he's talking about how when he was young, there were clerks who would do manual calculations. And that's all been changed by manual counting machines. So he writes, in the clinics and hospitals of the near future, we quite reasonably expect that the doctors will delegate all the preliminary work of diagnosis to machine operators as they now leave the taking of a temperature to a nurse, and with much more confidence in the accuracy of the report than they could place in the members of a Royal College of Physicians. The observation of symptoms is extremely fallible, depending on not only the personal condition of the doctor, who has quite possibly been dragged to the case by his night bell after an exhausting day. I definitely relate to that. But upon the replies of the patient to questions which are not always properly understood, and for lack of the necessary verbal skill could not be properly answered if they were understood. From such sources of error, machinery is free. So this is 1918, and Bernard Shaw is already identifying many of the factors that we would point to today that cause diagnostic errors. Now, historically, AI has been seen as a large solution, and I'll say historically from roughly the 1940s through 1992, and there were some very impressive AI systems historically. The most famous one is AAP Help, or the Leeds abdominal pain system. This was a computer-assisted system in the era before abdominal CTs that could make acute abdominal diagnoses better than any human. It was so effective that the US Navy actually put it on all their nuclear submarines with the thought, this is the Cold War. So if a seaman developed an acute abdomen, they did not want to take the submarine out of commission unless they had to. So very effective AI algorithms. Now, from roughly the 1990s through the mid-2010s, there was basically no improvement in AI. There were some pretty cool programs. I did not take them very seriously as someone who studies clinical reasoning because they didn't really have, they were difficult to use. They didn't really have much impact in the real world. Now, all of this has changed in the last 2 years, and a lot of these lessons that we talked about in the 1970s and 1980s about how to work with computers are suddenly very important again because large language models are the most exciting intervention in clinical reasoning in decades. Before I go further for the students, if you have ever used ChatGPT, can you raise your hand? Yeah, that's what I thought. Everybody. Who has used ChatGPT in their medical studies specifically? Yeah, almost everybody. This is what's going on with my medical students as well, and my residents. We're in a situation where the youth are the people who are the most advanced with some of these new technologies, and you're leaving us old folks like your professors behind. So I'm going to very briefly talk about how language models work, and then why this matters for clinical reasoning. this is why I wanted to talk about the psychology of reasoning. So a language model is trained on virtually all available human text, all the internet, tons of pirated books. Basically, these companies scrub everything they can. And what they do is they split the text into pieces of words, tokens. That's a kind of basic unit of semantic meaning. And they're using an algorithm called a transformer, which very conveniently can understand and predict the next token in a string of tokens. Well, that's kind of how human speech works, right? We don't just have individual words. Words exist in sentences and paragraphs in order to have meaning. And then they put it through a very complicated training process. There's a pre-training where they give good inputs and good outputs. And then there is a fine-tuning process called reinforcement learning by human feedback, where they actually sit down human beings to look at good inputs and good outputs. And if the computer says, if the algorithm says something good, they basically give it a thumbs up or a cookie. If it says something bad, they give it a shock. It's a Skinner box for training an AI model. And what ends up happening, this is a Star Trek reference here, but what ends up happening is that it is able to create human speech that is remarkably human-like. If anyone, well, it sounds like everyone has communicated with these algorithms, they're very good in Spanish. Unfortunately, they're not as good in every language, but they're really good in English, they're really good in Spanish, and they're really good in Chinese. And they're pretty good in other languages. But it's like talking sometimes to a human being. And I should say, I did do this so I could do a Star Trek reference, but this same technology to predict tokens, these transformers, can be used for virtually any type of creative output. I'm sure all of you have created images with AI. Now you can create videos. You can clone people's voices. I showed Dr. Carrillo a video of a fake patient, a synthetic patient that was fully powered by AI that you could talk to, that you could communicate with. So these technologies are advancing very rapidly. But here's the question. Why does this matter for clinical reasoning? Why should a system that can predict the next word, basically like, in Google when you predict the next word for Google, why does that help us make diagnoses? So I'm going to share with you a real case that I made a diagnostic error in, and the patient died. So this was a middle-aged man who presented with months of night sweats, dramatic monocytosis, daily fevers, quotidian fevers. He had ground glass opacities on the x-ray. He had a history of BCG. So what is BCG is the treatment for bladder cancer. It's the old-fashioned tuberculosis vaccine. He did not get any better with antibiotics. His liver enzymes were elevated, and he had a history of spinal surgery. And this is a gentleman who I made a diagnosis in. I diagnosed him with endocarditis, culture-negative endocarditis, and he died. And 6 weeks later, this also happened to be in February of 2023, I got a result back from the state laboratory that told me that I was wrong. I was completely wrong about what he died from. He actually died from Mycobacterium bovis bacteremia. Very rare, very difficult diagnosis. I felt terrible. His wife was actually a nurse at the hospital. So obviously I was devastated not only by the fact that my patient died, but that I had made a misdiagnosis. But what really upset me is this was day 2 that GPT-4 had been released. And I pulled up one of my old notes, and I put that note into GPT-4, my thoughts at the time. And what did GPT-4 tell me? It told me that the most likely diagnosis was a mycobacterial disease, and the second most likely diagnosis was culture-negative endocarditis. If I had had this technology just 2 months before, 3 months before, he may still have died, but I don't think I would have made that misdiagnosis. So the reason that LLMs appear to be able to make diagnoses, and I can talk about this more in the evidence, is that the way that we, human clinicians, make diagnoses is semantic clustering. It's illness scripts. We use language, and this time it's language encoded in our brains, to make these diagnoses and to do system one thinking. An LLM is effectively able to do system one thinking at scale in a way that does not get angry, in a way that does not get tired. It doesn't need coffee to fuel itself. It doesn't get in a fight with its wife prior to coming to work, and it is always efficient. So as a researcher, my research is in human-computer interaction. The question is, how can we actually make, like, an LLM cannot take care of patients. So there are people in Silicon Valley who will say, we don't need doctors anymore. I think everyone here knows that is ridiculous. We need doctors. Doctors are always going, well, until every single job has been replaced by AI, we are going to need doctors. So the question becomes, how can we use these technologies to make us better at our jobs to better care for our patients? My opinion, and what a lot of my research on, is second opinions. There is reason to think, these are from human second opinions, that just getting a second opinion can drastically improve clinician performance. Depending on the site, second opinions can change the diagnosis between 1.3% and a third of the time. There was one review in Pakistan where a second opinion changed the diagnosis a third of the time. The best study is actually in the Netherlands and at Utrecht, where a new diagnosis was only found 13% of the time, but a new treatment was offered 56% of the time, and patients felt better almost a third of the time. So there's reason to think that second opinions are very effective. So with that, I've talked a lot. I want to show you the technology, so I'm going to invite Dr. Carrillo up to the stage. Is this microphone working as well? No, it's okay. I'll go up there to run it. So, is it on?
Hello, hello.
Okay. So this is what we are going to do. I have a real case, one of my own patients. I'm going to present 4 pieces of information. Dr. Carrillo is going to tell us his thoughts, and then I am going to go up to the control room and, using some of the prompts from our studies, actually run it through an AI. And what I want all of you, Dr. Carrillo is one of the finest internists that I know. So Dr. Carrillo is going to tell us how he thinks. And at the end of this, I want you to tell us your reflections on what it was like to work with an artificial intelligence. Are you ready?
Listo, si mi doctor Mella me da el permiso para equivocarme sin miedo a la crítica, así que...
And I'm also going to have the AI communicate in Spanish, so it won't just be in English.
Bien.
Okay. So this is a real patient of mine. This is this is a patient from Massachusetts. So there are going to be epidemiologic factors that are different. This is a 19-year-old man with no past medical history aside from a recent COVID-19 infection. This case is in 2022, so this is during the COVID pandemic, who presents to the emergency department with increasing dyspnea. He is found to be hypoxemic to the 60s on room air. So this is when I'm seeing him. So 2 months ago, this man presented to the emergency department with several months of diarrhea, malaise, fatigue, and 20 pounds of weight loss, in addition to a few days of flu-like symptoms. At that time, he was found to be COVID-19 positive, and he received the drug Paxlovid for 5 days. His symptoms improved. Then 3 weeks prior to this admission, he presented to the hospital again with dyspnea and fatigue. At that time, he was saturating well on room air. He had a CT angiogram with no evidence of a PE, but he had diffuse ground glass opacities in his lungs. His COVID-19 antigen was positive again. He was sent home from the emergency department with a recommendation to see his primary care doctor. Then 2 weeks ago, he came back to the emergency room with dyspnea. At this time, he was found to be hypoxemic to the low 80s, and he required 4 liters of oxygen. COVID-19 again was positive. He was treated with steroids with dexamethasone as well as remdesivir. Well, he was admitted to the hospital and discharged a week later after he got off oxygen. So now he's back at the emergency room, increasingly dyspneic, and now hypoxemic to the 60s. He's in respiratory distress, unable to give any additional symptoms. So when I met this patient, he could not really talk, and he was admitted to the ICU initially on high-flow oxygen, but then was intubated because of respiratory failure. He does not take any medications. He lives by himself. He is a baker, so he actually works in a bakery. He does not speak English. He's Portuguese speaking. He was an immigrant from Cape Verde, and we do not know anything about his social history and nothing about his family history. Dr. Carrillo, can you tell us your thoughts?
Bueno, gracias, Dr. Rodman, por este caso tan facilito. Si alguien quiere pasar en mi reemplazo, bienvenido. Bueno, voy a partir con mi representación del problema. Este sería un hombre adulto joven que tiene una historia subaguda, porque lleva semanas, meses, una historia subaguda de un compromiso del estado general que inicialmente comprometió el sistema gastrointestinal con una diarrea aguda en vías de prolongación y que luego comprometió el sistema respiratorio con una disnea progresiva hasta la insuficiencia respiratoria aguda severa y que tiene compromiso bilateral pulmonar. Esa sería mi representación del problema hasta ahora con la información dada. Yo diría que desde ahí, en mi esquema de gravedad, el paciente está en una disfunción orgánica aguda severa, que es la insuficiencia respiratoria aguda que requirió soporte ventilatorio. Por lo tanto, por supuesto que este paciente había que llevarlo a una UCI.
So, of course, we had to take these patients to the ICU, and we see there was a lack of opportunity in the previous appointments for not having accurately assessed the gravity of the situation. So we don't know if the patient effectively is in shock, and it has a respiratory deficiency. He has, so he is now in a grave situation and has a subacute diagnosis with commitment to the respiratory system. If I wanted to order my priorities right now, I would say, first of all, I'm going to combine the use of categories of illnesses with anatomic systems. So if I wonder anatomically where the problem of this patient lies, one of the possible answers is that it lies in a structure that has an effect on several other structures. So if I believe that he may have had diarrhea because of something in the gastritis in his stomach, I have to also take into account what could compromise his lungs.
Respiratorios, ¿no es cierto?, que evoluciona hacia la gravedad y que las opacidades que estamos viendo
to see how this can all be combined and to make sense of how the illness have evolved, the opacities in his lungs, and the other symptoms. Then, if I think about infectious categories, I need to think specifically about infectious categories of the second order.
Por favor, un aplauso para mi doctor Mella que
please, let's have a hand of applause for Dr. Mella who dared to join me.
Lo voy a abrazar porque ahora no me
I'm going
siento
to
solo
hug
en este
him
esfuerzo.
because I don't feel alone now in this effort.
Así que si
So,
pienso en infeccioso,
if I think about infectious
parece ser
diseases,
como lo más intuitivo,
which
pensaría
intuitively
en cuestiones de
is
segundo
what
orden,
makes
no
more sense,
necesariamente
I
en
would think
una
about second
bacteria, que es
order
lo más
infectious
habitual.
diseases, not a bacteria, which is would be the most common thing to think about.
Sino que es posible que esté pensando
it is
en
possible
bacterias
that I'm
no
thinking
habituales,
about
o sea, no el clásico gram positivo,
uncommon
gram
bacteria,
negativo, pueden
not
ser
the
bacterias más
not the
latentes
classic
como
big positive, big
micobacterias.
negative,
Me parece rara la
but
presentación de todas
maybe
maneras,
microbacteria.
multisistémica
It's
para el tipo
still
de tuberculosis
strange
que tenemos en Chile, que es
the
principalmente pulmonar, y las extrapulmonares
micro-
son más bien menores en frecuencia.
considering we are in Chile, but we could be thinking about viral situations that has compromised not only several systems, and we could be looking at consequences after viral infection. But I can't identify an obvious illness script, and this didn't come to mind so quickly. Hopefully, Dr. Mella is going to say it because he's wiser than I am, but that would be my assessment of the problem, of the gravity of it, and my use of an anatomical category.
Gracias, amigo. No, excelente el
Thank
análisis.
you.
Yo no
No,
hubiera
it was a
sido
great
capaz de hacer
analysis.
eso. Pero
I
ahí
wouldn't
yo
have
quiero
been able to
reforzar,
do
sí
that,
quería
but I want
preguntarle al
to
Dr. Rodman.
emphasize and ask
El paciente
Dr.
es un
Rodman.
hombre joven que habla portugués en
The
Estados Unidos.
man
Entonces, el
is a
paciente
young patient who
inmigrante de
speaks
Brasil o de
Portuguese,
Portugal.
an immigrant.
Brasil. Ya, entonces eso inmediatamente, porque aquí lo importante es que... Claro, tenemos primero anamnesis remota.
We have remote anamnesis. We have an immigrant from Brazil.
Entonces ahí tú le vas
And
agregando
this is something that adds to the scientific, to the analysis. He's an immigrant that comes from a country that has, for example, a high prevalence of consumption. Among the 5 top countries in the world. So I think this is a brilliant assessment. If he comes to Brazil, we could also consider HIV, whether it's positive or negative. It would be interesting to know what city and what sector he comes from. If he lived in a favela in Rio de Janeiro, the probability increases that he's dealing with a consumption.
Solamente para, muchas gracias, doctor Mella, y solamente para,
thank you, Dr. Mella.
Para hacer un punto teórico de lo que hizo el doctor Mella, él identificó rápidamente un modificador semántico que es el antecedente del viaje, que como ustedes ven, a mí no le di mucha relevancia y claramente eso tiene una relevancia absoluta. Y es lo que pasa cuando uno tiene que lidiar con una cantidad de información que no fue menor. Y por lo tanto, obvio que el doctor, que tiene mucho más experiencia, un foco en infectología, inmediatamente captura eso, su sistema
infectology goes to think where is the essence of this.
Now what happens is we will ask our computer colleague what they think, and as you can see, the computer is focusing on the exact same factors. So if I were to ask, and I will tell you, the computer did a lot better job than we did with this patient, but the number one thing that the computer thinks in this presentation is pneumocystis jirovecii pneumonia secondary to HIV/AIDS. So thinking infectious diseases, as both of you did, thinking of infectious diseases beyond COVID-19. Picking out, these are all based on semantic qualifiers, but picking out many of these factors. Only number 2 at a much lower percentage does the computer think severe COVID-19 pneumonia. Continuing going down, tuberculosis, mycobacterial disease is also on the differential. And you can, and you can see the factors that it's picking out. And then for number 4, having a very similar differential to our amazing human internists, other opportunistic fungal infections. Of course, pointing out that if these were the cases, there must be some degree of immunosuppression. Finally, at number 5, at the much less likelihood of interstitial lung diseases. So you can already see that very early on in the diagnostic process, the computer is displaying remarkably similar clinical reasoning to the human. Can we go back to the case on the PowerPoint? For the next aliquot of information.
¿Puede ir a las otras preguntas?
Okay. So,
muy bien.
Dr. Carrillo,
entonces,
in the ICU, the patient has a low-grade fever. This would be about a 38.8. Blood pressure is normal. Heart rate is 102. He's saturating at 95%. Of course, he is intubated, so I don't know what that means. On exam, he is thin, almost cachectic. He has tachycardia, but otherwise normal cardiac exam. I don't know what this lung exam means because he is intubated at the moment, so I have to imagine this is not true. His lungs could not possibly be
intubado, así que no podía ser bilateral.
And well perfused in general. So a fairly non-specific exam.
Así que no es bastante específico esto.
A relatively normal white count. His hemoglobin is 11.3. His CMP is relatively normal. A BUN of 18. Creatinine is 0.7. Sodium is normal. Potassium is normal. Chloride is 97. LDH, however, is 580. That is very high. The procalcitonin, I don't know why we sent one, was negative. Blood cultures were negative. His UA just had a tiny bit of protein. His COVID was again positive, and the X-ray now shows progressive bilateral ground glass opacities, much worse than the last time he was in the hospital. How does this additional information change your thinking?
Bueno, para volver a donde había quedado en términos de categorías de enfermedad, había dicho mi enfoque anatómico de algo común entre sistema gastrointestinal
was something related to the gastrointestinal system and lungs. I talked about infectious causes that I did not thought were related to this. It had to be a more atypical bacteria and viruses. So with that in mind, the first
creo que es llamativo,
thing
primero
that
el
caught
nivel
my
de
attention
insuficiencia
was the
respiratoria
level of
aguda severa que tiene,
respiratory
el cuadro
insufficiency.
es como muy
That's
subagudo,
because
más
the
tiende como a la
whole
cronicidad,
case
y
is
de repente
subacute
mucha insuficiencia
and a lot
respiratoria
of
creo que el
respiratory
examen físico,
insufficiency.
el hecho que
I think that the
esté
physical
caquéxico,
exam, the thing that
se
he is
correlaciona bien
cachectic,
con esta
is
historia
correlated with
subaguda
this
acrónica, y ahí uno
subacute history.
empieza a introducir un modificador semántico que es inmunocompetente o inmunosuprimido.
It introduces a semantic component which is
leve,
suppressive, and he also has a slight
con la evolución en el tiempo. Y tiene esta LDH severamente aumentada, que ese sí es
LDH
un
is
modificador semántico
highly
porque
elevated,
nos acota
and
bastante
it
el
is a
diagnóstico
semantic
diferencial cuando
modifier
tenemos un hombre
which
adulto
limits
joven
our
con un síndrome
diagnosis.
constitucional de curso crónico y
He
que
also
tiene un
presents
compromiso
anemia,
gastrointestinal
and
y respiratorio
it commits
progresivo severo hasta la insuficiencia
the
respiratoria
gastrointestinal system and the respiratory system as well.
LDH aumentada,
With
y
with such
linfopenia,
high
muchas
LDH,
gracias, mi doctor. Uno tiende a pensar que el
one
paciente
would
está
tend to think
posiblemente
that
inmunocomprometido, que ese
the
inmunocompromiso
patient has
podría ser compatible con VIH,
his
y
immune
que,
system
una de las
compromised,
principales
and it could be
infecciones
compatible with
oportunistas en
HIV.
VIH es el neumocistis, y
One
muy
of the
compatible además
main
con el
with
aumento de
one
la
of the main
LDH.
symptoms
¿Qué
is
otros
pneumocystis,
diagnósticos
and
diferenciales
also
con
the
esa
increase of
representación del
LDH.
problema se me ocurren? Todos empiezan ya a sentarse en la categoría infecciosa.
Might be
No olvidarse
related
que
to this. They all come
la
to this
LDH es un indicador
infectious
como
area.
general de destrucción celular.
LDH is a characteristic of cellular
que produce
destruction,
estos quistes
and
pulmonares, entonces en algún
pneumocystis
momento incluso se puede relacionar con neumotórax
produces
espontáneo.
these cysts,
Pero hay otros cuadros
which might
infecciosos que
produce
también
pneumothorax,
producen
but
elevación
there
de
are
LDH.
other
El COVID fue uno de
infectious
ellos.
diseases that might
El
produce
COVID
this,
grave también daba
like
este
long COVID,
compromiso bilateral con
which
posible LDH
gives
aumentada.
this
De hecho, eso se
bilateral
considera un
compromise.
factor de pronóstico de gravedad. Si el doctor Mella no me
now,
corrige,
if
pero
Dr.
en mi esquema
Mella
también
might
está la
correct
tuberculosis
me,
como
we also talk
como
about
un posible
TB
compromiso pulmonar
as a
y de
probable
LDH aumentada.
lung compromise.
Así que yo creo que el
So
examen
I
físico
think
y el
that the
laboratorio
physical
acotó
exam
a la
and
categoría
the
infecciosa,
laboratory exam
y
guides us to
neumocystis,
this
tuberculosis, COVID
infectious
siguen siendo
diagnosis.
los
When we
primeros en mi
so pneumocystis and TB are still the first on my list.
Perfect. Let us, I'm going to, are you able to scroll down? So let us see what our computer says. So the computer, like you, Dr.
Perfecto. Veamos
Carrillo,
qué dice nuestra
is
colega
even more
computadora.
confident that
El
pneumocystis may be
doctor
causing this secondary to
como el
HIV
doctor Carrillo
AIDS.
está
And if you see,
muy
the
confiado en
only
que
thing that it
los
says doesn't fit now is the fact
neumocísticos
that we don't know
podrían
the
estar
HIV status of the
causando
patient. If we can scroll down,
este
let's see what
cuadro.
else the computer is considering.
Vamos a ver qué
So
más
it
está
still thinks that
considerando.
less likely severe COVID-19.
También piensa
CMV
que
pneumonitis,
menos probablemente
which would,
podría
again,
ser
require, that's a very
un
rare
cuadro de
diagnosis and would require
COVID-19
immunosuppression.
severo.
ARDS, that's a relatively non-specific diagnosis.
RDS,
Interestingly, it's
que es
considering lymphoma
un
now
diagnóstico
likely
poco
because of the
específico.
elevated LDH, so it's pointing out that that seems far less likely.
Esto lo
So, Dr.
está
Carrillo,
considerando
how
por
do you,
los niveles
this
elevados de
differential, is it
LDH,
similar to what you were
de
thinking?
LDH.
Después de la segunda licuota, creo que el guión de enfermedad de neumocystis fue evidentemente más claro.
After the
En la primera, a mí no me vino a la cabeza rápido neumocystis,
the diagnosis of pneumocystis was clearer. I tried to, at first it didn't come to mind immediately, but I need to, I tried to get out of my headspace to consider
Can we pull
this
up the case
information.
again so I can give Dr. Carrillo the third and fourth parts of the case?
Podemos poner
Are
el
you pretty
caso de
confident
nuevo
that it's pneumocystis at this
para
point?
ver las siguientes partes de
No he cerrado no he
esto.
cerrado mi diagnóstico diferencial.
Okay.
I'm still not 100% sure that it's
So,
pneumocystis.
CT chest was performed, which showed symmetric severe pneumonia, partial ground glass in the upper
El
lobes, densely
eco
consolidated in the lower
pectoral
lobes,
fue
no
realizado
cavitation.
que
The ANCA was
mostró
negative, and this was the point at which we
un
finally tested
agrandamiento
the HIV
leve
antibody. We also performed a sputum culture, which showed PMNs, neutrophils, only sparse respiratory flora with no acid-fast bacilli seen on the smear. I'll go ahead and do the fourth part as well.
Bueno, acá está la cuarta fase del caso. La histoplasmosis de orina fue negativa, el estreptococo en la orina también negativo.
CMV viral load was negative. However, the serum beta D-glucan
La
was greater
carga
than
viral de
500.
CMV también negativa.
Aspergillus antigen not
El
detected.
serum beta de
And then,
glucano
the
fue mayor a
gram
500.
stain from our bronchoalveolar lavage showed 2+ neutrophils with no microorganisms.
Se mostraron
so how does this affect your thinking?
dos más leucocitos polimorfonucleares.
La primera
sin microorganismos.
que con la segunda licuota habíamos planteado
Okay,
que
so
los elementos nuevos de la segunda
first
licuota
part
nos
has come
permitieron con más
to
claridad armar un
fulfillment.
guión de
The
inmunosupresión por VIH.
Immunosuppression that allowed us to propose the possibility of immunosuppression by AHV, and the script that was originated in this part about
Me
pneumocystis.
gusta que hayan hecho un ANCA
I like
porque no me siento tan
that,
solo cuando dije vasculitis en algún
they
momento.
did
Así
an
que
ANCA
parece que los colegas
test
de Harvard pensaron igual que yo, así que lo cual me enorgullece.
It gives away that they had a similar thought process as mine, and
apoya la moción.
beta D, and according to the beta D glucan, the doctor supports my notion.
Yes. Exactly,
Sí,
and I won't run it through the AI again because I'm pretty sure I know what the AI is going to say. So this
Voy
patient,
a poner
in the end,
la
the
inteligencia
BAL
artificial,
culture
estoy
returned
bastante
positive
seguro
for
que va a
pneumocystis
decir
cerevisiae. His CD4 count was
el
less
examen
than 10, so he had
resultó
AIDS.
positivo
And this
para
patient, when I took over his care, we were treating him
Girovechi,
with Bactrim, steroids, and we
y
started
el
him
paciente
on
fue
triple
tratado
therapy
con
for
Bactrim,
HIV, and
esteroides
he improved
y
dramatically.
Biktarvy.
He had a very
Él tuvo
complicated,
una
as you point out,
estadía
Dr.
complicada
Carrillo, very
en el
complicated course
hospital,
with multiple pneumothoraces, requiring
con
multiple chest
múltiples
tubes from the blebs from the PJP.
pneumotoracis,
He was in the hospital for very long.
intubaciones.
However,
Estuvo
after
un largo
5 months in the
tiempo
hospital,
en el
he
hospital
was discharged
y
successfully
después
home and
de
has made
5
a
meses
full
fue dado de
recovery and is
alta
doing well to this day.
y
The last I checked, it was
ha
several months
realizado una recuperación
ago.
exitosa.
So, wonderful job, Dr. Carrillo. Thank you
Así
very
que
much.
un trabajo maravilloso, Dr. Carrillo.
Dr. Carrillo, I am curious about
Dr.
your
Carrillo,
thoughts because I will tell you, the ICU team and the
intrigan sus
emergency room,
pensamientos
we're not thinking about
porque,
PJP. And one of the
déjeme
things that I
decirles que
find
en
remarkable
los
about the AI is
salas de
that it
emergencia no estaban
immediately
pensando
pulled out
en
the
esto.
fact that PJP
Y,
was the most likely
pero
diagnosis.
lo que me impresiona de la
What
inteligencia
are your thoughts
artificial
about working,
es que
like working through this case and also having the AI
el
recommendations?
PJP
Bueno, primero,
fue de los primeros que consideraron.
al lado,
Well, this is the first time that I've done
fue
the
impresionante ver
exercise with
cómo
side by
realmente
side with
ChatGPT fue
ChatGPT,
capaz
and
de
it's
ser mucho más
amazing to see
específico.
how
Yo
it
creo
was
que mi
able to
razonamiento
be
tendía
even
a
more
mantenerlo
specific.
muy genérico con la
I
primera
think
licuota,
my reasoning was pretty
porque
general.
como les dije,
with
no
the
logré
first part of the
enganchar
information.
rápidamente en mi sistema 1 con un guión
My
de
system 1
neumocystis en VIH.
wasn't immediately
Creo que
hooked with
estaba
the
bastante nervioso
script
también,
of
así que
pneumocystis.
eso juega a mi favor. Pero fue impresionante
It was
realmente
impressive,
como las entidades
truly,
nosológicas mucho más
how
precisas
they had
salieron desde un primer momento, y
many
eso
precise
valida
entities that
también un poco
came
las
up
teorías de aprendizaje del guión de
immediately.
enfermedad,
And
porque
this
obviamente que
varies the
el descubrir
theories
patrones para una
of
inteligencia
learning
artificial
of
es mucho más
illness scripts.
disponible que todo este contexto que no lo está viviendo ChatGPT, que nos está hablando aquí frente a decenas de personas.
This context is
así
not
que
being
fue tremendo, pero
experienced by
también como
ChatGPT,
que
so
tuve un
it's quite
exagerado,
impressive. But
una exagerada
I
inclinación
also
a no
was
sesgarme por los
exaggeratedly
títulos que me estaba
inclined
dando
not to be
ChatGPT,
blinded by the
entonces
titles
me
that
mantuve muy como
ChatGPT was
exageradamente
throwing at
abierto a
me,
las posibilidades.
so I stayed very open to the possibilities.
Did you feel that the recommendation from the computer
¿Sentiste que
changed
las
your mind in any way?
recomendaciones del computador cambiaron su opinión de alguna forma?
Yo creo que
Well,
cuando
I
vi
believe
el
that
neumocystis,
when
sí,
I
dije,
saw
oh,
the possibility of
pasó.
pneumocystis,
sí,
I
dije,
said,
oh,
oh
sí,
yeah,
porque
I
vi
didn't think
neumocystis
about
y
that
dije, "Uy, pero un
because I
hombre joven,
recognized it.
con un cuadro
I
respiratorio
recognized the
progresivo,
symptoms
me
because
despertó un poquito el compromiso
the fact that he was
gastrointestinal inicial, lo encontré
young,
muy largo.
the patient was young, threw me off.
Claro, sí,
But
cuando miré el título y miré de nuevo
after
la
I
viñeta,
looked at the
dije,
title and
sí,
then
puede
back
haber un guión aquí.
at the vignette, I certainly considered the possibility.
Yeah.
I want to compliment, I want to highlight the
Disculpe,
importance.
profesor. Yo quiero volver a resaltar, creo que ha sido extraordinario esto para todos, porque todos estamos aprendiendo, pero vuelvo a insistir, la anamnesis remota.
Of remote
Brasil.
amnesia.
¿Ya? Y capaz que era de Río de Janeiro, no importa. Segundo lugar,
the remote anamnesis.
importante, y que hace mucho más difícil el excelente análisis que hizo el doctor
Secondly,
Carrillo.
and this makes the excellent analysis by Dr. Carrillo even more difficult, is that the patient presented gastrointestinal symptoms.
Yeah.
And that was probably not because of the pneumocystis itself, but the base illness. Thirdly, the physical exam.
O tenía tuberculosis o tenía una enfermedad que le producía una inmunodepresión.
He had either consumption or an illness that produced an immune system depression.
Pero aquí viene la diferencia entre el
And
mundo
now
desarrollado y el
here
nuestro.
comes these are the difference between the developed world and our world. What mortality rate do these patients have in your hospital?
Sorry, what's it?
What mortality rate?
Oh, for PJP, very low
For
mortality.
BJP, we have very low mortality. Para la pneumocystis tenemos baja mortalidad. In our medium, in this category of illness, 50 to 80% of patients die. And that is the difference between the medicine of the first world and our world.
Y hubiéramos escuchado más de alguien, no, este enfermo está perdido.
We have heard from more than one person, no, this patient is a goner.
En este enfermo,
and
con
this
este diagnóstico,
is
que creo que no
so
hubiéramos
that
andado tan mal el diagnóstico,
this
no
patient
hubiéramos
with
jugado
this
por la siguiente
diagnosis,
alternativa.
we
Hubiéramos
wouldn't
dado,
have
aparte
missed
del
the diagnosis
cotrimoxazol,
probably,
obviamente,
but we would
esteroide,
have bet
le
on
hubiéramos dado una
the following
porque hay
alternative.
demostraciones
We would
en
have given
pacientes
him an
inmunodeprimidos celulares no VIH que en neumonía grave por pneumocitis viroesi, la adición de una equinocandina al cotrimoxazol puede mejorar el pronóstico.
Because
De manera
it
que a
may
nosotros nos
have
ha ido tan
improved
mal
the
con estos enfermos
prognosis.
que de partida nosotros
So
hubiéramos partido
we have
con
done
esa
so
combinación.
poorly with these
Muchas gracias,
patients
disculpe.
that we would have started with this combination.
Thank you very much to both of you.
Muchas
And
gracias
I
a
will
los
say this
dos.
patient
Ahora,
almost died multiple times.
este paciente casi falleció muchas veces.
All right. I will,
Muy
this
bien.
is This has been a wonderful discussion.
Ha
I'm going to
sido
go over
una
the
discusión maravillosa
scientific research
y
on
voy a ir a la
LLMs and diagnosis very
investigación
rapidly
científica
because I think
rápidamente
we've already gone over
porque
time, but I do
creo que
want
ya
to
nos
show some
pasamos un
of the
poco del
data.
tiempo, pero sí quiero
So,
mostrarles un poco de la información.
LLMs encode a massive
Entonces,
amount
los
of knowledge. If you were to give an LLM a standardized test right now,
si se
it
le
would
da
pass
una
above the level
prueba
that any
estandarizada,
human doctor could even possibly
pasaría
They also are
cualquier
able
número
to
de
communicate
los
with
médicos.
patients more empathetically than
Y
humans. This is
además
actually what some of my own
se
research has
comunica de
shown, which
forma
is
más
quite
empática con los
depressing for
humanos,
humans.
lo cual
But
puede parecer
patients, in
bastante
many
deprimente
senses,
para los
it's only
humanos.
mediated via text, but they prefer talking to LLMs than
Y
talking to human doctors.
muchas veces los pacientes prefirieron hablar con
They can make
estos sistemas que
diagnoses.
con
As we
los
demonstrated here,
médicos. Como
an
se demuestra
LLM
aquí,
at this
estos
point is
sistemas en
capable
este
of
punto
making
es
a
capaz de hacer
diagnosis
un diagnóstico
far more accurately
mucho
than
más
any
preciso
human
que
clinician. And the
cualquier
latest
médico.
models, the model
Y
that
los
I just showed you
últimos
is 01.
modelos,
I can talk a
el
little bit
modelo que
after
les
if anyone
mostré
wants to talk
ahora,
about
el
it. It
1,
uses something
podemos
called
hablar de eso
internalized
más
chain of thought
tarde.
reasoning. It can solve a New England Journal CPC at about a 90% accuracy. In comparison, humans can solve that. The best humans can solve it about 20% of the time. So it shows superhuman abilities in solving cases. Now, they also have as you could see, a really remarkable sense of probabilistic reasoning, which doesn't make sense because they're only predicting text. But this is a study that I ran. LLMs have a more probabilistic understanding of the world than humans do. That is, they have a better understanding of the pretest probability of disease and how different diagnostic tests change that probability. Now, it is not perfect. It is not an epidemiological understanding because, again, they do not experience the real world.
No experimentan el mundo real.
Their intuition is far superior
Sin embargo, y aquí voy a poner comillas, su intuición es
they can
mejor a la
forecast
de los humanos.
diagnoses. And this is based on old data. This is a study that's way out of date now. But they are able to say with much more accuracy than humans what the most likely diagnosis is. And they can show clinical reasoning. This is very important for when we think about how we're going to implement these things to make humans better. They are able to display human reasoning. In this image, the red is the computer, the green is attending physicians, and the blue is residents. So as you can see, attending physicians display reasoning better than residents, but the computer far outpaces both of them. And without any loss in efficiency, accuracy, or cannot miss diagnoses, though they do what's called hallucinate. They make up information, which is concerning if you think about how high stakes medicine is. And I think anyone who's used ChatGPT is familiar with the concept of hallucination. Now, this gets to my research. One of my questions is how do we make people better? Because, to stress again, no AI is going to be taking care of patients. Human doctors are going to take care of patients. So the question is, how do we make humans better? This is a study from Google that was caused a lot of consternation in my field because what it showed is that humans by themselves did the worst. Humans doing Google search did a little bit better. Humans doing the AI did better, but the AI itself did the best. And this flies in the face of the traditional axiom of informatics, which is that the human plus computer will always do better than computer alone. Unfortunately, this study will be published in JAMA in 2 weeks. I ran a randomized controlled trial that showed the same thing. We took a very powerful AI system and randomized doctors to either use it or not in solving difficult cases. And you can see in the red, the AI system drastically outperformed humans. The green over there is humans plus the computer. There was no difference in the humans using the AI between the humans alone. And the reason, as we dug very deep into the data, is that humans love the AI when it agreed with them. When the AI disagreed with them, they just disregarded the information. We did another randomized control trial on management decisions. So Dr. Carrillo talked a little bit about management reasoning, which I have not talked about. Management reasoning is very complex. And you would not think that an LLM could do management reasoning, because how could it understand the context of the patient? Now, this study did show that the LLM made humans better at management reasoning. But when we did a subgroup analysis of the data, the reason was quite depressing. The AI was not actually better at
razón es bastante deprimente.
The AI
Y es que la inteligencia artificial era mejor, por ejemplo, en darle instrucciones a un humano para disculparse en el caso de cometer un error o trabajar en conjunto con otros colegas. En otras palabras, la computación hizo que los humanos fuéramos mejor en cosas que ya deberíamos ser buenos. Y este es otro estudio, soy un profesor visitante también en Google. Y pueden tomar un historial de pacientes mejor que los humanos cuando se hace una prueba Turing. Otra cosa en la que pensaría que los humanos son mejores, el computador también mostró la posibilidad de hacer esto. Entonces estos programas pueden hacer estos diagnósticos. De hecho, tengo un sistema en mi hospital ahora donde los pacientes están dando recomendaciones. Ahora, no pueden tomar decisiones autónomas. Estos sistemas, cuando tiene que tomar una decisión definitiva, no le va particularmente bien. Supongo que están entendiendo lo que digo, que es que los sistemas no podrán practicar la medicina. La pregunta entonces es cómo trabajamos con ellos. Me voy a saltar esto. Ahora, algo que es bastante preocupante es la razón por la que no les va bien solo es que todos tenemos es que estos sistemas los ocupamos más para confirmar los diagnósticos. Así que tienen las mismas ideas, los mismos preconceptos que tenemos nosotros.
My research, and then I will end, is not so much about building models. I do some work with models and for oversight of reasoning, but really my research is about how do we make humans better? What factors are necessary to make these technologies work well with humans? We don't have a good answer thus far. At this point, most of our interventions have not worked very well, even though the technology is capable of outperforming humans. So there are this is a brand new field, and there are a lot of open questions. And then one of the things that I worry about, because I am a medical educator, all of the medical students here, it sounds like everyone uses LLMs. At my medical school at Harvard, most of my medical students use LLMs. One of the questions that I have is, we know that in order to train doctors, we need to learn to use our brains. And learning to use our brains is not fun. It requires us being wrong. It requires us making guesses. It requires us, unfortunately, doing the wrong thing to our patients and then getting feedback so we can train our brains. Everyone saw how effective that O1 was at making that PJP diagnosis. This patient was seen by some of the smartest doctors at Harvard who did not make that diagnosis, but O1 did. How are we going to train a new generation of doctors when right now any one of you can go online for free and use this technology? I don't know the answer to that. I think this is a unique challenge in medical education. I think this is a very exciting and also very scary time to be studying clinical reasoning and be learning to be a doctor. So that is it for my talk. I want to thank everyone for having me. I am so impressed with all the physicians here, and it has been a true honor. Thank you very much.
Agradecemos al Dr. Rodman por su increíble presentación y discusión de caso clínico. Y finalizando, damos pasos a una mesa redonda que será moderada por el Dr. Jaime Lastra. Invitamos a nuestros exponentes a unirse a esta discusión, donde podremos profundizar sobre los temas presentados y responder las preguntas que nos han mandado.
Adelante, por favor, Dr. Mella. El doctor Carrillo ahí agarró la misma silla que tenía, ¿cierto? Doctor Rodman. Han hecho llegar algunas preguntas. Vamos a comenzar las rondas de preguntas que pueden ser, la mayor parte de ellas, para la mesa en general. Partiendo por la primera que nos llegó,
one we
de una
have
alumna de medicina,
is of
que
a
nos
student
pregunta a
of
todos
medicine,
qué rol tendrían
and
las
she
guías
asked
clínicas y
us
la
what
evidencia
of the
científica
role
en el
of
establecimiento de la
clinical
tecnología
guides
como
in the
principal método
establishment
diagnóstico.
of technology
¿Qué futuro le ven
as
a esto
the
y a la
main
integración de las
diagnostic
inteligencias
tool.
artificiales en la medicina? ¿Cómo incorporar el razonamiento al perfil
How do we
curricular cuando las mallas
incorporate
clínicas
clinical
se
reasoning
encuentran colapsadas?
to the
¿La
syllabus when
inmunosupresión se considera un
they
signo
are
o un
collapsed?
síntoma del
The
razonamiento clínico?
immunodepression is considered a
Relacionado a
symptom.
la medicina interna. Entonces,
This is a
la
topic
pregunta a
related
quien
to
quiera tomar el
internal
micrófono en
medicine.
la mesa es
The
sobre el
question
rol de
is
la guía
addressed
clínica y la
to
evidencia
whomever
científica,
wants to take
¿cierto? En el
the
establecimiento de la tecnología,
microphone.
la aplicación de la inteligencia artificial en la
It's about the
medicina
application
y cómo
of
incorporar el razonamiento
artificial
clínico
intelligence
al
and how
perfil
to
curricular y
incorporate
si es que consideran un
the
síndrome o un síntoma de
clinical
inmunosupresión en el
reasoning
razonamiento clínico.
to the syllabus. These are several questions into one. I'm going to take the last two questions about clinical reasoning in the current syllabus and with whether immunodepression is a symptom or a syndrome. First of all, the clinical reasoning in the syllabus, we have to talk about whether the present model has reached its goal or not. Ending Medical Reversals is a beautiful book in which this was reflected upon, and in the model of the new era, we should stem from clinical reasoning and then get to basic sciences, because then the students will be more mature and in need of deeper answers. And whether the immunodepression is a syndrome or a symptom, I would say none of the above. I would explain it as a functional category, because
Hernán, parece que se le agarró las pilas también al... Vamos a reponer las pilas.
The batteries ran out of the mic. Of the batteries of the microphone ran out. Okay, so these are a functional category to coordinate other syndromes and symptoms. Dr. Mella, I completely agree. I want to take this opportunity. I'm very grateful that I was invited to participate in this seminar. I want to take this opportunity to discuss immunodepression. It's a condition that explains a lot of base pathologies that lead to several diseases. During the morning, we have talked, for example, about this protozoa infection that exists in New England that has to do with immunocompromise. And in this last interesting clinical case, we saw a very interesting case of cellular immunodepression through an infection from HIV. The important thing is that the student and us, along with us, can handle this concept of immunodepression and understand what branch of immunity is compromised. This is traditionally done in the pre- and postgraduate. One of the basic concepts that is insisted upon is the humoral immunodepression, the lack of synthesis of antibodies. For example, in plasma cells, nephrotic syndrome. On the other hand, we have this case that was very well presented by our colleagues of a cellular immunodepression that is mediated by T cells. An incredible example is this pneumonia from pneumocystis, which was one of the first descriptions of HIV-related infections. And in the middle of this lies the answer. All that goes from skin and mucous and getting to to cellular response. Why do you think the mortality rate from pneumocystis is much more higher in Chile than in the United States? Well, it has to do with the possibility, with accessibility to treatment, human capital. We are far from what they have in the United States. However, considering what we are as a country, we have a we don't do so bad. In a local article, we propose that consumption is a reflection of the degree of human development. This was written in a local magazine. The United States has a prevalence of approximately 2%. 2 out of 100,000 prevalence cases of consumption. Chile has 16 to 17 for every 100,000 prevalent cases of consumption. And Brazil has even more. First of all, these patients arrive too late, but there is also a problem that has to do with the instruction of postgraduate students. When talking about treatment for this patient, we still have some rejection and some bias, and how, for example, this patient was submitted to all these surgical processes and was then intubated, and then the conclusion was reached that he was suffering from HIV. I think this explains the question that was asked in great measure. A question for Dr. Rodman from the audience.
Yes.
Considering the language models that are trained by humans, by biased humans, how reliable can they be as second opinions for diagnosis, and how can we make sure that they become a reliable tool? Eso probablemente sea la pregunta más importante. Los modelos de lenguaje son entrenados en un número limitado de lenguajes humanos, entre los que afortunadamente se incluye el español. El inglés, el español y el chino son los idiomas principales, pero reflejan todos los sesgos humanos. Y esto
I think it is a mistake to think of language models as anything but biased. Because they are a reflection of human language, they can only be biased. So the question, I think it's the wrong question to ask, how do we make them not biased? I don't think there's any way to make them not biased. The question is, knowing that they are biased, but knowing they are also powerful, how do we make them work better? That is one of the reasons I think everyone in this room is going to have a job. I'm not worried about AI models taking anyone's job because they aren't capable of doing the things that our very strange brains that have evolved over millions of years of evolution are capable of doing. And one of the answers is epidemiology, is having a scientific understanding of disease. Understanding, for example, that the context of Chile means a patient with PJP and HIV is going to do very different than the United States. Those are contextual things that humans are good at. Now, there are computational strategies that can make LLMs better. One of them is called retrieval augmented generation. I showed Dr. Carrillo actually, has anyone here used open evidence? Oh, what do you guys use open evidence for? To study, yeah. So open evidence is an AI model using retrieval augmented generation that effectively reads all of PubMed. So when you ask it a question, it reads effectively all the medical literature known to man and gives you an answer. And that's an example of a computational technology that makes them more accurate and honestly makes it very helpful for me when I'm taking care of patients, because now I can read millions of articles and get the answer at a patient's bedside, which is amazing. I mean, the fact that I can do this is almost a miracle of science. It doesn't abrogate the bias in these models, and I think all of us need to be aware of that, is that there is no way for a language model to not be biased. They are they are a reflection of our brains, and they have, very strangely, they appear to have all the limitations of our brains also.
¿Estará por ahí la doctora Carolina Muñoz? ¿Sí? Doctora, el micrófono es suyo porque quiere hacer un comentario. Hagámosle llegar el micrófono.
Hola, muchas gracias. Yo soy Carolina Muñoz, soy médico, residente de psiquiatría infanto-juvenil y docente de la asignatura de razonamiento
and teacher of clinical reasoning in the San Sebastián University. First of all, thank you very much for this space. We need to start talking about clinical reasoning. We do not learn clinical reasoning as we want you to learn it now. We learn to do this reasoning by looking our teachers, our tutors, and the truth is that we do not need to do this anymore. We do not need to do it intuitively if we have acknowledged the key elements that allow a doctor to make decisions efficiently. What we saw here today, which was to see how an expert expresses their thought process. It's something wonderful that allows those of us who do not know that much to analyze this structure. I am pretty sure that you also have come to this situation when you study something and you do not reach the same conclusions that a teacher does, and you think to yourself, why did I not achieve this? And it is because we structure our thoughts in a different way. So the problem then is not that we lack, or maybe sometimes yes, but it's not the lack of knowledge, but the structure. One thing is medicine based on evidence that helps us a lot, but the other thing is medicine based on experience. And that those that can transmit this, those who know more or that have been more around this area, is something that we need to learn. What happens is that medicine now is so quickly developed. We have, like Doctor said in the beginning, put a lot of trust on technology that we forget the process of making decisions, our own decisions. So hopefully we are always conscious about the way we structure our knowledge, as we saw today. Hopefully we do that, and in this way, in our subject, we talk about these metacognition processes, and we think about how, in the way we think, because we make more mistakes because of the lack of attention or alteration in our thinking processes rather than lack of knowledge. That is why this is important. And I might think, okay, there are no that many alterations in my thinking process, but of course when you are at 3 a.m. or maybe in a rush, it is quite easy to make mistakes. When I am aware of the fact that it's not only about what I know, but how I manage what I know, I might make less mistakes, and the impact of that in public health is huge. So I would also like to highlight the generosity with which we have talked about mistakes. We in medicine do not talk about mistakes because it's not well seen. We might get punished, and it is something not real. We make mistakes. We make more mistakes than what we like to, and it is something we need to show to be able to grow. I would also like to tell you that the University of San Sebastián, and trying to also comment on this question, we updated our syllabus to incorporate clinical reasoning, and we started to talk about this theoretically, meaning metacognition, process of thinking, what is mistake, why do we make mistakes, how to face these mistakes. We talk about uncertainty, something us there, how much can we trust in that, in this, and nothing is 100% because we work based on probabilities, nor certainties. There are always going to be doubt, and it is something that we need to know from the start. Did you see the difference when they complemented the knowledges? That was perfect. But when Dr. came here, we shed a light in this case. So it is really important to talk between colleagues and other professionals that have something to give here. Things that we do in medicine, not only physicians, but also nurses, social assistants, psychologists. Medicine is not only what we do. The healthcare system is a whole system, and that's why we need to share the decision-making and clinical reasoning. Here I have some of my students, and they are taking clinical reasoning, and after seeing physiopathology and semiology, are taking clinical reasoning too, analyzing clinical cases from the basis, the narration of the patient, trying to transform that semantically, and even in the idea, because we might make mistakes in that. He was tired because he had problems in the legs, right? So trying to transform this and reach to the specific problems, building these narrations in the diseases. We have 2 more clinical reasonings to structure. It is a tiny group, the one that is working in this, but we do this with a lot of love and the certainty that this new way of learning medicine is going to make easier not only to reach this diagnosis, but to solve problems in general. I'm sorry to be so long on this, but I wanted to tell you that.
Thank you, Doctor. We thank your contribution because it helps us visualize the reality that we're living in this university and other universities in the region. We were ambitious in organizing this as a round table, and we try to also express that through streaming. But one of the things that you said at first was how we can use this artificial intelligence. So, Dr. Rodman, how can we make the implementation of this use of language models of artificial intelligence make the students think more rather than think less?
I don't know the answer, but I can tell you what we're trying at Harvard. So one of the things that we do not want to do is for people to rely on language models to make decisions. So when we have our clinical reasoning sessions, we have groups and people work together in groups. And one member of each group is assigned to use a language model. They're actually assigned to use the artificial intelligence. The other members of the group are not allowed to use an artificial intelligence. And the idea is that one person interacts as a mediator of collaborating with the AI and then reports back to the other students. We don't want a situation where people just put the information in, but that the AI is treated as part of a team. And by doing this, the hope is that they can learn the uses, but also the limitations, because there are many different types of limitations. So right now at Beth Israel and at Harvard, not every single, but most of our clinical reasoning sessions will have an AI reporter, 4 or 5 of them per class as part of the discussions. And the hope is that by communicating as a group that way, we can use them to explicitly teach reasoning rather than being a replacement for reasoning.
Muy bien, ¿qué les parece si les damos un aplauso a esta mesa redonda? Habían algunas preguntas más por honor al tiempo y que debemos hacer un reconocimiento a un profesor destacado que nos está visitando ahora.
Will not be able to answer them in this session, but we will make sure that the questions get to the teachers and also to Dr. Rodman through email. Thank you very much to all of you.
Con esto damos por concluida la jornada
With
de semiología y
this,
razonamiento clínico.
we finish this
Agradecemos
session
profundamente a
of
nuestros
clinical
expositores,
reasoning. We
organizadores y
thank
a
our
cada uno de ustedes.
organizers,
Muchas
everyone
gracias por su
present
asistencia
here.
y que tengan
Thank you
una
very
buena
much for your attendance and have a wonderful day.
Antes de que se vaya,
Before you leave,
Dr.
Dr. Rodman, could you please come here to the
en
stage?
nombre de la Facultad de
In name of
Medicina
the Medicine Faculty of the University of Concepción, and in name of our decana, Dr. Ana María Moraga, who is represented by Mrs. María Fernanda Bello, who is the tutor of this career. She will give you a diploma.
Profesor más que destacado y visitante de esta universidad. Así que les pido que por favor pase al centro, del escenario.
Please come to the stage.
Y aquí le vamos a hacer entrega de un símbolo de nuestros 100 años como Facultad de Medicina,
of
donde
our
se destaca
100
como
years
visita
as a
distinguida del
medicine
Dr.
school.
Rodman para de esta
Thank
primera
you
jornada
very
de
much for
semiología y
your visit
razonamiento
in this
clínico. Y
first
otro regalito
seminar
que el Dr. Mella
of
también le
clinical
incorporó aquí, que
reasoning
esto
and semiology.
no estaba presupuestado, la verdad, pero por
w-
gentileza de él se lo hacemos llegar igual. Y ahora sí, muchas gracias por su asistencia y
yes,
esperamos
thank you
tenerlo
very
en una
much for
próxima
your
versión.
attendance,
Gracias.
and we hope for your participation in another opportunity. Thank you.